We on?
Can we see people coming yet?
Yes, already. Yes.
Excellent. You can see people appearing on the screen as we sit here. It's 1 minute past 9 o'clock here in Australia where I am. It's 7 o'clock in the morning in Brazil and Argentina, and we have people joining us from time zones all around the world. So welcome everyone to our Logic webinar. My name is David Pilcher. I'm an intensive care doctor in Melbourne, Australia. It's good evening from here. It's good morning from South America. Probably good afternoon for most of Europe, Asia, and Africa. As people join over the next couple of minutes, we'll start in a second. But it's a real pleasure for me to be part of this group and to welcome all of the speakers from so many different places around the world to tell us about intensive care in their countries and tell us about their registries. There's a little bit of housekeeping I'll let people know about, and then I'm going to hand over to my friends and colleagues, Jorge and Pilar. The speakers are going to be talking for 12 minutes. Attendees listening in, please put your questions into the questions box that you can see on your Zoom screen. The moderators, we will keep an eye on the questions, and at the end of each session, we'll run over some questions, discuss a few things with our panelists, and then move on to the next session. So we'll introduce each speaker immediately, one after the next, and do the questions at the end. To the speakers, as George has been saying, as people come online, we'll get you to all be in the moderator session with us. Keep your cameras off and microphones off while the speakers are talking, and we'll move from speaker to speaker as we do so. And I recognise that some people will be coming on right now who haven't had a chance to have a look at their talks, but I'm sure we're going to make this work. It's been working so far, and I'm really looking forward to seeing what everyone has to say. So my job was to fill in the first 2 minutes before we went on to some real speakers. So I'm going to hand over to Jorge, who's going to give us a little bit of the background to Logic, and then on to Pilar, who will introduce our first speaker. So Jorge, over to you.
Thanks, David. Thanks for the introduction. So, hello, I'm very happy that everyone is online with us in the different time zones, and acknowledge that this is a huge collaborative effort as Logic is. I'm going to give you a little bit of background on Logic, and I think that for the purpose of understanding what Logic is and what is behind it, I think that we have to go many years ago, even before Logic existed, because the basis of the existence of Logic is the existence of national intensive care registries themselves, and they have been around for more than 3 decades now. If we follow, for instance, the examples of ICNARC in the UK, ANZIC's Core, as represented here by David Pilcher in Australia, New Zealand, and so many others that have been around for a long time, the Dutch registry, NICE, etc. So because these large databases, data sets of intensive care units, countrywide or regional data sets exist to improve our understanding of case mix, epidemiology, resource use for intensive care patients, we could 5 years ago start, let's say, a very casual discussion or conversation between initially Dave Dongelmans from the Dutch registry, me representing at the time the registries enabled by EpiMed, mostly the Brazilian registry, Uruguayan, Colombian registry, and also Rashan Hanifa and Abby Bean representing the critical care Asia registry at the consortium at the time. And we started discussing if we have such a large amount of data that has already enabled us and helped us understand the epidemiology of critical illness and outcomes and improve quality of care in regions and countries. How can we use this to compare the different health systems and outcomes? Is it feasible to work together in ways so that we could improve definitions, understand better what core data sets are, and potentially do research together because we were sitting on millions of ICU admissions data, and the possibilities seem to be immense. And actually, what happened, and it was our perception, was that this was feasible and this was something that we were willing to do. So we decided to give it a go. And as I mentioned, it was casual conversation, but it really turned up to be something feasible. So we started with the concept of having Logic as an independent consortium, because it has to be inclusive, it has to be international, it has to be open, so that every member, being every intensive care practitioner or every medical society or every national registry, could feel as a part of the group, belonging, but also having Logic as their own project. And that's how we began. And it quickly increased to a broader initial group that included Pilar from SATI-Q in Argentina, David Pilcher from ANZIX, Bertrand Guidé from the Paris registry, Cubrea, and others joining progressively. And over the years, I'm very happy to say that even with a pandemic in the middle, we could get to the point that we actually could collaborate. As you are going to see during the next hours, we had made a lot of progress. The progress was because of individual registries themselves. And there are amazing perspectives and lots of possibilities of what we can do together. And I'm sure that we'll be able to mention it in detail in the end of the sessions, so that you can have a flavor of what's coming next and how you can potentially participate. So this is short story of and short background of how it all got started. Individual initiatives joining together to be able to explore the synergies of data and explore the synergies of the expertise that's reflected here in this amazing lineup that we have for the sessions today. And hopefully, with no other interest than trying to do things that we are already doing in a better way, this is something that will keep growing over the next years, thanks to all of you. So back to you, David.
George, thank you very much. Thank you for giving us the background to Logic. And it's been a great experience for me being involved and seeing other people get involved too. I'm going to hand over to Pilar now, who is going to take on the next part of the session and introduce our first speaker, and we can start to hear from the individual registries around the world.
Hello, good morning, good afternoon, good night for everyone. Thank you, Jorge and David, for the introduction. And thank you all of you for joining us in this Logic Day, as we called this event. And on the session, we are going to invite Stefano Finazzi from Italy. Stefano represents il gruppo italiano per la valutazione degli interventi in terapia intensiva, and he will present us the project. Please, Stefano.
Okay, thank you. Thank you for the introduction, and thanks for the invitation. It's really an honor to be here, to be the first speaker of this session. Can you see my screen?
Yes.
Yes.
Okay, perfect. So we are, I think, the last group that joined Logic just a a couple of months ago. So we are here in Italy, just in the center of this map, and that's our logo. So the GVT group, which stands for Italian Group for the Evaluation of Intervention in Intensive Care Medicine, was born in 1991. So now it is more than 30 years old. And with the idea to create a system to collect data speaking the same language. So to find a way to have the same data definition, the same way to get data, to make possible the benchmarking among Italian ICUs. So the principle of our group, as all the other groups of LOGIC, I guess, are collaborative research. Try to develop new indicators to assess the quality of healthcare in our ICUs, and then to improve clinical practice with those tools. Basically, we have two systems that we use to collect data. The first one is ProSafe, which is, say, a sort of registry. Now it involves about 200 ICUs in Italy, plus someone else abroad in Poland, Hungary, Slovenia, Greece, Israel, and Cyprus. In the database, we have more than 1 million patients, and the database grows with about 80,000 patients more each year. So the second tool that we have to collect data is Margherita 3, which is an electronic health record developed by our institute, Mario Negri, which is the institute where I work in Milan, and by our network, GVT. So it's basically the same, we have exactly the same medical record in each ICUs, about 70 ICUs in Italy. It has been designed by medical doctors, nurses, and researchers all together to have a unique tool to support and improve clinical practice, and at the same time to collect data for clinical research. Actually, today I won't focus on Margherita 3, but on ProSafe, which is, as I said, our registries. So the parents of ProSafe was called Margherita, which in Italian means daisy, because the idea was to create a tool, a modular tool with the core data sets common to all patients and all ICUs participating in the project, containing basic information like anamnesis, comorbidities, diagnosis, a few severity scores measured at patients' admissions or during ICUs or during the first day of ICU stay, some pharmacological and non-pharmacological treatments, complications in ICUs, and outcomes. And then we have this modular structure in such a way that we can extend the set of variables that we collect on some particular categories of patients, like, for instance, infected patients, patients undergoing cardiac surgeries, and other kind of patients. And to make possible to ICUs to participate, to join projects if they want. I mean, so it's not mandatory to participate in all the project, of course. The software was developed by ourselves with a lot of internal quality and coherence checks in such a way that we can guarantee the quality of the information we collect. These are a few examples of additional modules that we have. Mostly of them are about, say, the big topics of infection and colonization in ICUs. So we run projects about to study the spreading of, for instance, multi-drug-resistant bacteria, to study healthcare correlating infections, also in collaboration with the Istituto Superiore di Sanità, which basically is the Italian NIH and the European ECDC. Then we have some additional modules on specific surgeries, like cardiosurgeries. We have 15 ICUs participating in this project with about 8,000 patients per year, and 6 ICUs participating in a module on liver transplantation with about 500 patients per year. Even if the focus is on the ICU stay, so the period that all these surgical patients spend in ICUs, we collect also some preoperative and intraoperative variable in such a way that we can say measure performance and compute indicators not only about the ICU but also about the whole surgical path of the patient. Then we have a project about usage of resources in ICUs. So the idea is to compare available resources in terms of human resources and devices and structural resources, like for instance, even the room structure, the organization of beds in rooms. And we compare those resources with the required resources by patients, adjusting, say, for patients' features. So the main work that we do as a coordinating center of this network, based in, as I said, in Mario Negri Institute, is to produce national and ICU reports. So every year, and sometimes even more often, we develop reports to, say, be able to benchmark ICUs and to picture the national situation. It's possible, of course, to have reports also on specific Italian regions or on specific type of ICUs. And the core activity for us is to benchmark ICUs with respect to their mortality. So every year we develop a prognostic logistic model using about 100 variables, and in such a way that we have, say, a national standard which is always up to date. So every year we have a model which represented our Italian average performance. And with this model, of course, we can assess here on the left, you see a forest plot with the SMR of all our ICU. So we are able to stratify ICU and to classify ICU according to their performance. And then, of course, we are able also to provide information, more information specific to each ICU, for instance, comparing the expected mortality according to our model with the observed one. Furthermore, we have a web tool that can be accessed by our users, so basically by doctors and nurses of our ICUs, where they can ask analysis on themselves in real time on update data. So in such a way, they don't have to ask every time to our coordinating center, and they are able really to perform basically any kind of analysis that can imagine. And so they can, for instance, choose the model to start to adjust mortality. They can stratify about patient condition at admissions, and then they can have any kind, basically, of descriptive report, or this is, again, is a comparison between observed and expected mortality for specific ICUs, and here it's a performance of the ICUs in time. So in this way, we can make the ICUs, in sense, autonomous, and they can assess themselves their quality of care. Then we have some projects with some Italian local governments to try to improve the quality of care. So basing on a panel of indicators that we have developed together with clinicians and with the policymakers in those regions, we define some improvement objectives, and we can try to assess if thanks to our projects, the quality of care is improved. This, for instance, is a recent results in Piemonte, where you can see that basically every group of colors is an ICUs, and you see that there is a positive trend with the shortening of length of empirical antibiotic therapy during times for the ICUs that adopt this indicator as an objective for the year. And that's some quite a bit older results in which you see again the indicator is the length of the empirical therapy. That of course it should be reduced in favor of target therapy. And here you see that the situation was very bad before the starting of the project in 2016. And then our ICUs keep improving during the years, and also the variability between among ICUs, as seen by the width of the box plot, was really reduced. Then, of course, we can also do some try to address a lot of research questions in very different topics, thanks to the fact that we have this modular structure, and so we can design studies on specific topics. And that's the last few slides are just to tell you what we plan to do for the future. So we would like to create a data sharing platform to share our data together with tools for data management analysis, so that researchers can access our platform, try to answer their questions. And of course, the idea is to have everything completely free and shared. So we shall ask researchers to make their codes and results free and available on the platform. So that's more or less the structure that we want to, that we have already implemented and we have already tested. So there is a database in the background, and there is a server with Jupyter Hub for the analysis at which we have, of course, we can connect with in a collaborative ways with several clients altogether. We have just tested, as I said, in an event that we did in Milan a few weeks ago, a datathon. This was just an Italian event, but since it was very successful, we plan to make another event in more or less 1 year from now, an international event, and we hope to invite you to that event. These are the order of magnitudes of, so we have about 50 participants divided in 6 teams, and there's a number of queries that all our participants made on the database in those 3 days of competition. And so where we are, I think we are quite good in collecting data, engage ICUs, creating reports, and improving the quality of care using our tools. Of course, to be improved, the number of publications that probably are too low. So I think the GVT is not very known abroad because of these problems. To try to strengthen national institutional collaboration and also international collaboration, and I hope this the participation in LOGIC is the first step in that. So thanks to everyone and to my teams for what they do every day. Thank you.
Stefano, that was incredibly impressive. Thank you very much indeed. We've got more people joining online. Welcome. We're having presentations, and we'll be putting you can put your questions into the questions and answers box while the speakers are doing their talks, and at the end of each session we'll come back and go over some of the questions with the speakers. So it gives me great pleasure to move from Italy to Pakistan and to introduce María, who is going to be talking about the Pakistan registry. And I'd just like to ask all of the speakers just to introduce themselves briefly just before they do their 12-minute talks. So thank you very much, María. Over to you.
Hello, thank you, David, for your kind introduction. I think you have to allow me to screen share first. So greetings.
Actually, I can't stop my sharing. Sorry. Okay, thank you.
Okay, so greetings to all the listeners from all over the world, I'm sure in various time zones. And it's a great pleasure to be here. And I'm very grateful to the LOGIC team for giving me this opportunity to share with you my journey of setting up an intensive care unit in a registry in ICUs in Pakistan. So Pakistan is quite a large country. It is 5th largest country in the world, population-wise, 240 million people. And it is in the South Asian region. So as you can see in the map, 8 countries in the South Asian region, they collaborated to form an organization to promote economic growth. It is commonly known as the SATI-Q region, that stands for South Asian Association for Regional Cooperation. So the SATI-Q region and these 8 countries, they make up only 3% of the world area, but they are home to more than a quarter of the world's population, and obviously 90% of the burden of disease. Intensive care medicine as a specialty is still evolving. We still have physicians who practice pulmonology, medicine, anesthesia, and who look after ICUs. It's only in the last 7 or 8 years that we have training programs and we are producing pure intensivists. So obviously this ICU becomes a service-driven practice and there leaves little time for research. And the research, the intensive care access is also very limited. As was reported in this study, the number of ICU beds per 100,000 population in low middle income countries is far lower than a high and upper middle income countries. And Pakistan falls in the bottom 3 countries when it comes to ICU beds. So we did a survey in 2018 in the teaching hospitals across the country to document the critical care infrastructure and resources in terms of human resource and equipment. And it highlighted the fact that there is quite a lot of inequalities in access, even within the provinces and between the provinces. And we documented about 220 intensive care units, but only about 12% of these ICUs are managed by people, doctors, physicians who are trained in intensive care medicine. Since COVID, the situation has improved quite a lot, and as our training program is getting more organized, we have more people, but still there is a shortage of intensivists in the country. So with this background of resource constraint, we started our journey of introducing research projects in ICUs. So I'm very grateful to Rashan, Hanifa, and Abby Bean, who are the driving force behind the Critical Asia Africa network. So the first registry in a low middle income country in South Asian region was set up by them in Sri Lanka. And they were very kind. They visited Pakistan in 2017, and at one of our anesthesia conference, they presented the idea of setting up a registry in Pakistan. Obviously, most of the participants were very impressed, but they were also very skeptical that such a thing is not going to work in Pakistan because of our culture, because of how data is considered very secret and nobody likes to share it. So So there were only 5 ICU doctors who wanted to start this journey of setting up a registry and collecting data. And this is how Pakistan Registry of Intensive Care was born back in 2017. Today, we have more than 80 ICUs part of this collaboration from 38 hospitals, and it covers all the provinces across the country. And the hospitals are both government hospitals, private hospitals, teaching hospitals. Mostly they are teaching hospitals, but a few non-teaching hospitals are also part of this network. Then Wellcome funded the collaboration for research and training in critical care in Asia and Africa, and the mandate was to set up critical care registries in 15 countries, evaluate quality, and eventually become a platform for clinical trials. So as you can see that Pakistan Registry of Intensive Care is part of this large federation of registries, and both in Asia and in Africa. So now I'm just going to tell you how we have used the price infrastructure to do research in ICU. So at the pandemic, ISARIC and WHO had given out standardized CRFs to collect COVID data to characterize the disease. And with the help of this registry infrastructure, which was already present in many African and Asian countries, we were able to contribute data to this platform. ISARIC has also now come up with a COVID-19 long-term follow-up studies, and we have embedded the forms in our registry platform, and this is a prospective study, and we try to take informed consent before the patient leaves ICU. The numbers are very small, and so far we have only had like 15-20 patients in ICUs with COVID, but they were very happy to give consent, and especially when we contact them, they are quite cooperative, which was against what we had expected. Then REMAP-CAP is a trial everybody is familiar with, and Pakistan, along with India, Nepal, and Malaysia, contributed many patients. And I'm also very thankful to Timo Tolpa and Isra Javed, who guided us how to implement this complex trial, because prior to this, we had no practical experience of running any clinical trial. So we have contributed 449 patients so far. The trial is still ongoing. We are also doing MEGAROX, which is a mega trial with a sample size of 40,000 patients, comparing oxygen, conservative and liberal oxygen therapies. And it is also done through the registry, and Pakistan has contributed more than 3,000 patients so far. Genomics is a project, Genetics of Mortality in Intensive Care, from University of Edinburgh, and Pakistan is the only site in the CCA network that has implemented this study, and we are using the dry blood spot cards to collect samples, and the registry has also been adapted to generate the genomic ID, which was something new for us. Then CCA has a study protocol, a mixed method study for combining the stakeholder-led rapid evaluation methodology, combining with the near real-time registry to facilitate evaluation of quality. And we are very thankful to Duncan, who has guided my team, especially in Pakistan, to go through this whole complex process of evaluating the different processes. So we had chosen mechanical ventilation, and my unit chose the process of head of bed elevation, which was not done consistently. So they went through the whole process, mapping, observations, and they have come up with recommendations. And now the next step will be to implement an intervention and show if the quality improved. So I am just summarizing that with the research, the price infrastructure, we have been able to do observational follow-up studies, clinical trials, quality evaluation, and it's a tool for benchmarking as well, because each unit has access to their own data, as well as they look at the whole cumulative data. So they can benchmark themselves how they are doing as compared to the rest of the ICUs. PRICE has also a steering committee. Members are from across the country as well as external members, and Abby and Rashan are observers. We have developed a data management plan. We also have data access guidelines, and data usage agreement can be used if somebody who's not part of the collaboration but would like to use the cumulative de-identified data for any research project. So data security at the institution level obviously is a responsibility of that institution that owns their data. They can publish the data and use it as ever they want to use it. As Search is acting as a curator of the data, and we enter into an agreement with each unit so that we can basically curate the data, but each unit has access to their own data. Now, just very recently, one of the provinces, which is the second most populous province, but it has the highest density of ICU beds per 100,000 population. So they have mandated Search to access all the public sector ICUs. So the purpose is that it will enable ICU bed surveillance. It will also define resource utilization, and the government might want to evaluate the quality and then improve the quality. And it will also enable disease characterization in the region. So this is the dashboard that will be shared with the government officials to let them know what the number of current number of admissions are, what are the beds, what is the bed availability, and what is the general case mix of critically ill patient in this province in the country. And in future, nobody knows if dengue, God forbid, might be the reason for the next pandemic, but we, together with ISARIC, the registry network will be collecting data to characterize the disease better. And the other project is that we would like to find out the prevalence of sepsis in Pakistan, which we'll do within our registry network. So last year was the first annual get-together of the PRICE collaborators, and just this Sunday we are going to hold our second meeting. So thank you very much for your attention, and I'm ready to answer any questions if you have. Thank you so much.
Thank you, María. It was very interesting, your presentation. There are some questions that we will leave for the end of the session. And now we are going to present Wangari Sika from the Kenya Intensive Care Registry. Welcome, Wangari. You can share your screen.
Thank you very much. Can you see my screen?
Perfect.
Thank you very much. So good morning, everyone. Good afternoon, sorry. My name is Wangari. I'm a consultant in anesthesia and critical care at the Aga Khan University in Nairobi, Kenya, and I'm the national lead for the Kenya Critical Care Registry. So registries in Kenya are not a new concept. In fact, Kenya has had registries for sickle cell disease, for heart failure, cancer, for a number of years, but there hasn't been one for critical care until we came on the scene in 2021. So how did our registry begin? In 2018, we published a paper in the Annals of Intensive Care that showed that 54% of the ICU patients we had in our facility died. This study raised more questions than answers, but it was also incredibly difficult to perform, given that our study was retrospective, paper-based, very, very difficult to conduct. The take-home message for us was the need for a database of some sort of registry to explain our outcomes, improve care, and support research, as we had no idea what was going on with our paper-based processes. In 2018, I met with a team from ICNAC who were very willing to support us in our efforts to create a registry. But their process involved paying for involvement in that platform. We didn't have any funding, and therefore that was not an option for us. In 2019, I had the privilege of meeting with Rashan Hanifa at one of the American Thoracic Society conferences. And based on that meeting, we had a 3-month pilot of a registry at my institution in Nairobi. That then informed the efforts that followed thereafter. When the COVID pandemic began in 2020, we once again revisited our thoughts about having a registry that would support care during the pandemic. In May of that year, we applied to the Canadian Institutes for Health Research for a grant to support the development of a registry in several African countries, including our own, but we were unsuccessful. Thankfully, later that year, in August, a UKRI call for a similar project led to us resubmitting our application and being funded for a project that would support the development of a registry in Kenya and 8 other African countries, a total of 9 countries over a period of 18 months. So to implement the registry in Kenya, we began by seeking national regulatory approvals, which can be quite a process in itself. We then sought to house this registry within the Critical Care Society of Kenya, which then gave the registry a national face and not an institutional one. We set about assembling our team, looking for site leads and data collectors within each site, hiring a national project coordinator to help with logistics. And then each site then had to go through the process of getting individual IRB approvals. I'd like to introduce our team. We have Abby, Bean, Luigi, and Rashan Hanifa. And these are our site leads across the various sites in Kenya. There's Demet, Caroline, Ronnie, Nabukangwa, myself, Dr. IDOR, and Wambui. These are the visionaries who have fought hard to ensure that this registry is implemented in their sites. And this has been quite an uphill task for them, but has led to us being able to not only hit the ground running, but remain quite a force to reckon with, if you like, for the last 2 years. Each site then has a data collector. Most of ours are not clinicians. Some are intensive care nurses, some are pediatric nurses, but the majority are non-clinical. But they have been key in ensuring that data is collected on a day-to-day basis. We also have Chamira supporting us with IT, and Dorothy, our project manager. So site onboarding began with a call for participation through the various professional societies. We had hoped to recruit 13 institutions, and there were a lot of interested sites. Very many people wanted to be part of a project such as this, but it was very, very difficult to navigate regulatory approvals. And in the end, we have 3 private or not-for-profit facilities in our registry and 3 public ones. The data collection process involves a dedicated data collector per site. Each data collector underwent remote training, initially done by Chamira and now by Dorothy. And each data collector has their own unique login. We began by a minimal data set, just admission and discharge data, very basic clinical characteristics before we progressed to daily data. Each site was given a tablet, and we used the cloud-based platform called Protect. Here we see our site leads receiving their tablets and handing them over to their data collectors as the study began, the project began. For quality assurance and data validation, we had a process where the site leads would ensure that every week there was oversight over what was being entered into the platform, and there was validation of recruitment completeness through a validation process. We then had weekly Zoom meetings to keep track of every site, which then progressed to fortnightly when we were happy that everyone was more comfortable. Once the travel restrictions were lifted, when the COVID pandemic was easing off, Luigi was able to visit several sites. Here we see him visiting one of the sites in Nairobi to visit the teams there and offer support, which was really great. So we've had several outputs. Since we started our registry, we have close to 10,000 patients now registered, recorded in our registry. And each unit is able to keep track of their unit's performance because they have monthly reports available on the dashboard of the registry platform. We've been able to publish through the registry's efforts. We have a paper here led by Wambui that was published in PLOS One. It was our baseline landscaping study of close to 600 beds, ICU beds in the country. We have today received news that our EPOC study, that is the epidemiology of clinical care and outcomes in our country, led by Caroline Joki, has been accepted for publication today. We've been involved in a quality indicators prioritization exercise that was also published in 2022. And we've had several other successes. One of them is buy-in from our leadership, who've been able to accept our vision for developing a registry project in the country and supporting us in our journey. Dr. Misango from the Critical Care Society of Kenya, who was the chair of the society, allowed us to house it within the society. Dr. Majid was the medical director at my institution, and there I have our dean, Professor Atwoli. And through this, the support of the three, the registry has been able to grow and to flourish. We have been able to convert this sort of paperwork and data, patient data, into something easier to understand and manipulate and use. Other impacts have included publications in high impact journals. We've had presentations locally, internationally. We have visibility internationally now, and we've been invited to collaborate in various projects with researchers around the world who are like-minded, including the LOGIC team now. At my institution, we've been able to support a service query on ECMO. We've supported dissertations by our master's students and developed goodwill from our leadership at our institutions as they've seen the output of our work. Research mentorship has been a big push from us, and our site leads have been involved in the development of research projects, writing the protocols, and ultimately writing the manuscripts for submission. We have PhD candidates in the making, and we have quality improvements that are ongoing. Our data collectors have also been transformed into research assistants, and they are now actively involved not only in collecting data, but also coming up with projects and presenting them at conferences. We've recently also been included in what has been called Critical Care Asia Africa, which is a welcome funded community of practice. And we're very grateful for that opportunity to grow. But we have had challenges. One of our biggest challenges has been the fact that people are willing to participate, but they're afraid, just like our Pakistan team has said, of being exposed by giving out their data for such a registry. Remuneration has been a challenge. We've had to pay our data collectors separately for them to be able to participate in this study as it's over and above their daily duties. Data validation to ensure we have no missing data has not been easy, but we've had to do it regularly to ensure that we have complete data. Grant management and moving from one grant to another, as we have done in the process of this work, has also not been seamless and quite challenging in terms of contracting and starting new contracts with our new funders. That has led to pauses and hopes that we will restart soon in some of our sites because of this challenge in moving from one grant to another. Regulatory approvals in Kenya have been an incredible challenge. Getting approvals nationally and at site levels is really difficult. And it has also made it quite challenging for us to be nimble when it comes to participating in clinical trials. The additional regulatory steps for that in Kenya are quite many, and we're unable to participate, for example, in REMAP Cup, for example. As we look to the future, we see ourselves developing a stronger team in Kenya. We remain resilient in the fact that we hope that we will be able to influence national policy and have a truly national critical care registry. In summary, we've had significant challenges as the Kenya Critical Care Registry, but many successes. We've had local and international impact. We've seen the impact of shared vision and the power of networks and collaborative research, and we dream of a truly national critical care registry. Asanteni sana.
Your microphone's off, David.
Oh, sorry. After how many years should I know this? Asante sana, Wangari. Thank you for telling us about your registry and how it has developed. We'll come to some questions after the next speaker, but it gives me great pleasure from down under Dave to Dutch Dave to introduce Dave Dongelmans and the Dutch registry.
Thank you, Dave. We all thought that we are far apart, but in fact we very much look alike. And the reason that we found that out is that actually through this network. I'm just trying here to find the right screen. I think now I have it. So if everything works, you will now see my screen. As said by David, I'm David Dongermans. I'm an intensivist from Amsterdam. It's a great pleasure that I'm here. It's also a great pleasure.
We can see you, but not your screen yet.
That's strange. I think this will help.
Look. We're getting there. We can see your computer now.
Yep.
Computer, yes, but not. Yes, there you go. Great, go for it.
I'm sorry. So as I told you before, I'm very happy to be here. It's also very inspiring to hear the stories of others, to see that we share the same struggles, but also that we find different solutions. And I think that's one of the reasons why Logic it has a great potential. Share ideas and try to work together. The Netherlands is only a small country, as most of you probably know. It's only 70 million people. It's like a large city for some of you. It has 85 ICUs. The unique situation in the Netherlands that all ICUs join the NICE registry, of which I am the chair. We do a lot of the stuff we saw in other presentations as well. We have over 100,000 records in our database, as you can see in the upper right corner. Of course, we did try to do our job during the COVID pandemic as well. You see the waves coming through in the middle panel, the top. And of course, we helped the governmental organizations, such as the Dutch CDC, to help with managing the pandemic. We are, for a large part, transparent towards all the numbers of the registries. So the performance of registries is displayed in funnel plots and can be found online, again, transparent, of different groups and patients. And that's opposed to what we heard, for instance, from Pakistan and Kenya. This is not a great problem. And I wonder if talking about that would solve some of the problems Kenya had. What we also do is share data in between networks of registries, smaller and larger registries, intensive cares, help them look into what's the quality of care in different patient groups. Are the patients in the right place when they are admitted? The down left corner, there is the so-called actionable indicators, and I'll go into that later. These are the funnel plots, as I told you, transparent. 2 examples, medical patients and emergency surgery patients. Each unit can find its own dot here. And if you select them on the website, you can just see which unit is which dot. We also showed the performance of our ICUs over the years. We are not claiming that the mortality, the trend in mortality you see here is due to the fact that we have a registry in the Netherlands, but it's good to see that the performance over time shows some progress. Then same for mechanical ventilation. And as you see, during the COVID years, of course, the duration of medical ventilation was a bit longer. Public health, as I already told you, we started long ago with surveillance of influenza together with the Dutch CDC. And this progresses, of course, into the COVID years in COVID surveillance. And we're now into the progress of real-time data sharing with the Dutch CDC to be prepared for, let's not hope, the next pandemic. We also did some work to show that transporting patients between units does not necessarily mean that you do not deliver the right care. In fact, we showed for COVID that transferring patients from hospitals does not influence mortality. And it's, of course, during COVID, we were able to track patients over units, which we still think is very, very useful. Through our registry, we also recently had a great big discussion in the Netherlands about the number of beds we have. I think we're fortunate with the number of beds, but still you can't have enough. Not totally true, but still. People were saying we see a lot less admissions per quarter year. And that was true indeed. If you look at this slide, you see it 2021, the fourth, then you see that indeed there are less admissions. But it's the 80+ patients which were reason for the fact that we had less admissions. And this led to the idea that probably during COVID, those 80+ patients unfortunately died. And you see that slowly they're coming back into the picture of our ICU patients. And this led to the belief that we do not need to reduce the number of beds, but we still have to take care of those 80+ patients. I want to say a little bit more about actionable indicators, because I think that's one of the things we are extremely proud of. We try to help, of course, our units with enhancing the quality of care. And what we did, we developed together with the units indicators that if you present them to the unit, but more importantly to the people at the bedside, that they understand what they should do. This sounds simple. For instance, you know your tidal volume is too high. You know that you have to reduce your tidal volume. There are some other things that need to be in place. The data should be available. There should be variation, and there should be reason for room for improvement. What we then do is we present the data, but we also show them potential barriers when they are performing less than they want to at a certain indicator. And with the barriers, we also give them some suggested actions. And the suggested actions are actually evidence-based actions. So they're from the literature and supported by literature to help them to improve their performance on the indicators. So this is an example of a toolbox. This is on pain. We all know that appointment of a pain coordinator or team to ensure pain policy will help you in improving the care of your patients when it comes to pain management. And then we see these results over time. So you can track their results when they are using the quality indicators. That's what I wanted to tell you on NICE. So I focused a bit on the actionable indicators. It was a pleasure. Thank you for having me.
Thank you, Dave, for your presentation. It was very interesting. And now in the next 10 minutes, we will have the questions from the audience, and we have a lot of questions for all of the registries. Ariel Fernandez was asking to Stefano from Italy if you were planning to share your data using open standards as OMOP or 11 Health 7, and congratulates for your work. You know, if
Okay. I can cannot start my video, but I can. I think you can hear me, right?
Yes.
Okay.
Yes. Good.
So, well, up to now, we are trying to share the data from our electronic health record, Margherita 3, not yet from the registry. We are trying to solve some legal issues regarding to privacy, of course. So we have clear.
I can't hear. I don't know if you hear.
Maybe we have
Do you
lost it. Oh, no.
lost the connection?
That's a shame. Maybe he will come
No.
back.
Yeah,
Hey,
I think I'm back now.
Oh.
Sorry, I was kicked out. I don't know what happened. So as I said, we're trying to share now the data from our electronic health record, not yet from the registry. In that case, the data structure is quite complex, and we are adopting a data model similar to those to that of Mimic for those who knew of you that know it. The idea is to move to some more standard codification and like OMOP or HL7, of course. But the problem now is that we are technically we have prepared the infrastructure that I briefly present you just to try to solve some privacy issues. So the idea is not to move data, but to provide a secure server on which researcher can access without moving data.
Mm-hmm.
And the other option is to try to use federated systems, but in that case, I mean, it's very difficult because you have to rewrite all the codes in a federated way. So we are exploring different solutions.
Okay.
Okay.
Thank you. You want David? Yes.
Yeah. Can I adapt one of the questions that Ariel put in the into the chat? And this is probably a question to Dave and Stefano, but is aimed at the developing registries, the newer registries, and our Kenyans and our friends from Pakistan. How have you made your registry sustainable? How have you kept them going for so long? And are there any tips or tricks or advice that you can give to newer registries to make their registry sustainable and bigger and more effective? Dave?
Yeah, I think that's a very good question. So one thing is, and that's is also true for what we're doing here, is being inclusive all the time. So try to get people to join you out of free will. But of course, that's the part where you let people join and grow. But the sustainability also of care is the problem with finance. What we did in the Netherlands was just ask ICUs to pay some money, and not much, and start with that. And we're now in the process of being financed through government, which is in fact not the best place you can be, because your freedom is less. Whereas you pay yourselves, if of course the money is available, you have much more freedom to do what you want to do. So my advice would be inclusive and try to ask for the money of the units themselves. That also helps them to be committed to the initiative.
Interesting. Stefano, any words from you? And I'd be keen to hear from Madiha and Wangari as well.
Yeah, I agree with Dave. I mean, to keep units engaged, you have to give a way to access data and to show continuous results, so a sort of continuous interaction with them. like making reports and creating tools to provide them access to data. Regarding financing, for us is a bit more difficult, I think, than for Dave, because we cannot ask to, we don't ask money to ICUs. So everything we do for them is, say, for free. We are funded by a few local governments in Italy. So 2 regions and research projects. So for us, I think it's a bit more difficult to have a stable budget, and that's a sort of an issue, of course.
Okay, thank you. Any comments from María?
Yes, this is a very pertinent question, because we started off with our enthusiasm and very little money, but obviously that cannot go on. So I think of registry as a tool, as like a basic infrastructure, but it is the projects that you do then will eventually need to be funded. So like the clinical trials, remap gap, mega rock, so they come with a little compensation. And so it's the more projects a registry does, and it will attract more funding. And then the government involvement also helps, but as so far we have stayed away from involving government, just as the speaker said, that it becomes difficult as well sometimes if you involve the government. But in Pakistan, one province government has approached us. So our fingers are crossed. Let's see how that works out. We are also very careful in what we share with them and how it goes forward. But maybe if it helps them evaluate quality of care and quality is improved, maybe the government will eventually support the registry, at least in one province, and then that can serve as a model for other provinces. But involving government always has ups and downs. But I would think heavily dependent on the projects, research projects that you do to attract grants.
Okay, good advice. Wangari, any comments from you before we move on to the next session? Have we still got Wangari? I think we may have lost. We may have lost Kenya.
Yes, I think she's not here.
Okay. Maybe we should move on to the next session. Maybe I'll hand over the chairing responsibilities to Pilar, who'll continue, and Jorge, who'll take over.
Okay. Perhaps if there are some questions, the speakers then can answer directly in the chat. You can see in the question and answers to answer directly, and you could introduce the answer if there are ones not answered yet when María comes. Well, and in the second session, we'll have Amanda Quintairos from UCIS Colombianas. I think you're there. Thank you, Amanda, for coming today.
Hi, everyone. So I share my screen. Can you see my presentation?
Yes, it's not in the full screen yet.
Okay.
Yeah, now it is. That's good.
So thank you. I'm very happy to be here to talk about a little bit of this national registry that is just started 2 months ago. And Colombia is a country with approximately 51 million people. Is upper middle income country, and one of the most important healthcare systems in Latin America. In our current situation, we have approximately 865 hospitals with 8,338 beds. AMSI, that is our critical care society, Asociación Colombiana de Medicina Crítico y Intensivo, was born in 1996. And this part of is linked to other critical care societies. In this part of the Iberian American Critical Care Society in the World Federation of Societies in Intensive Care and Critical Care Medicine. This project wouldn't be possible if it was not the inspiration and motivation of the board, AMSI directive board members. They are located in 4 different hospitals that already started to collect the data. And as a result of an alliance between FEPICITIN and INDEPMED, we had the ICU Ibero-American Registry that extended through the continent, and now we have the ICU Brazilian National Registry in Mexico, Paraguay, Ecuador, Uruguay, and then we started to plan the beginning of the ICU Colombian National Registry through the cooperation agreement between AMSI, FEPICITIN, and INDEPMED Solutions for the implementation of the National Registry of Intensive Care in Colombia. The plan is we collect data from a structured database tool that is absolutely free of charge to collection, processing, storage, and analysis and propagation of data. And then we can generate indicators for improved quality and effectiveness. We have real-time benchmarking. We have had a website with the epidemiological registration profile, and the society and the EPMED provide an annual certification to the ICUs with the best performances. And of course, we all know that is a robust tool to clinical research. So in October 30, we launched the project with a webinar, which was very inspiring, where Salluh and Dr. Rezende told us with data and their experience in national registries. This is our website where we can know more about the project and start the creation of the hospital in the platform. As a current and future perspectives, now we have 6 hospitals collecting data. 4 hospitals starting the registration and creation of the hospital on the platform. And we are expecting to reach at least 20 hospitals in 2024. To read that, we have some information strategies and motivational strategies planned to discuss more about this topic, because in regional meetings there we have approximately 10 meetings to distribute all over the year. We have an AMSI National Congress in June of 2024. And a very interesting strategy is that AMSI has been divided in committees, and the ICU registry is linked to the research committee. So we are very focused to start to generate research in collaboration of all hospitals in Colombia. Muchas gracias.
Thanks, Amanda. Thanks for the presentation. We will follow to the next speaker, and as in the previous session, have questions and answers in the end, but you can all send your questions to the Q&A link here. Yeah, you're still sharing your screen, Amanda. So the next speaker will be Dr. Diptesh Arias. So Dr. Diptesh is an intensivist, one of the founding members of the lead of the Nepal Intensive Care Registry, and he's going to show a little bit the work of the Nepal Intensive Care Registry in the next minute. So Deeptesh, the floor is yours. Thanks for accepting to participate today with us.
Hello, everyone. Can you hear me?
Perfectly.
Yes.
Yeah, thank you. So I'm Deeptesh. I'm an ICU physician, and I lead the ICU registry that we have been implementing through Critical Care Asia and Africa Network and through Nepal Intensive Care Research Foundation. And currently, I'm also a PhD candidate at IDOR. So I'll be sharing some of the work that we have been doing through ICU registry within Nepal ICUs. So before registry, we did have ICUs, and there were as usual, there were clinical critical care delivery and other local research projects that were ongoing, but we didn't know that how safe are our ICUs. So we didn't have any data to measure the performance of our ICUs, and we always had this ambition of developing a learning health system where besides providing the clinical care and training, we wanted to measure the performance of ICU so that it can help us seamlessly deliver the quality improvement projects and help us measure the performance of ICUs and ultimately improve the patient outcomes. But we didn't have anything like that until 2019. So with support from CCA and especially Rasan and AV, we started this ICU registry in Nepal, and we tried to build this learning health system where we had a continuous data for evaluation and improvement from our ICUs. Our quality improvement projects were data driven, and we created a kind of community of practice where we can also invest on research capacity building and improving the research expertise within the local stakeholders. So earlier, it's not that we didn't used to do research, but instead of delivering the outputs of the research projects back to the bedside, most of us were were quite engaged or occupied with just publications. The findings of our study rarely went back to the bedside and didn't have much impact in changing the patient outcomes. But with the implementation of registry, we have few success stories and some outcome measures which have helped us improve our care delivery processes. So we wanted to develop something like that, and we established this registry. We were more focused on measuring the information on outcome measures, and which included like survival measures, the events of interest. We're interested in measuring the resource utilization, cost of care, and ultimately we would like to measure the patient-reported outcomes as well. And this registry has enabled us to fill that gap. So what we have been doing, we started with a few ICUs within the capital city, Kathmandu, and we started with 4 hospitals. And in the last 4 years, we have been able to expand it to almost 20 hospitals, and it has moved beyond a capital to other remote ICUs as well in other parts of the country. And with this, we have data on epidemiology, we have data on quality of care processes, we know the risk stratification and characterization of our patients, and we have started reporting the patient outcomes as well. And we are part of this broader network. So there are different ICU registry within Asia and Southeast Asia and few African countries. So we are part of this Critical Care Asia and Africa collaboration, and we're funded by the Wellcome Trust grant for our projects. And talking about our registry, we have a defined data set. There are core data sets, and there are a few additional data sets which we embed within our registry. We did the COVID surveillance projects, we did some clinical trials that were all embedded within the registries. And we are also doing some local research projects, and we are utilizing leveraging the ICU registry for our local projects as well. So, and we have a technical team locally. We have built the capacity within the country to implement the registry, and we have support from the CCA as well. And there are a few quality improvement projects. So just like Pakistan, we are more interested in care of the ventilated patients. So we designed a few quality improvement projects, and we have in the process of implementing these quality improvement projects across this CCA registry network. So I don't want to go into the details, but these are just some of the projects that we are working on, and some of them are about to be started. And what we do is we generate a report through the registry itself, and the participating sites, they utilize these reports, they measure their performance, and there's we also have a national kind of benchmarking, and each ICU can compare their outcome measures, the process measures, with the national the national outcomes. So we provide these reports regularly to the participating sites, and they have been able to utilize these findings for their care delivery at the bedside. And this is a protocol which has just been submitted and approved, and we'll be starting these quality improvement projects by utilizing the registry data soon. So basically what we have done, like we have realized that we need a comprehensive rigorous context-specific data and platform, which the registry has provided us. And registries have been instrumental in enabling us to report data on epidemiology, quality of care processes and outcomes. And this registry has helped us fill the gap. And as far as the sustainability and adaptation and scalability of the registry is concerned, so the finances are definitely a big concern, but right now we have the support from the grants. We don't have any support from the governmental organizations or ministries, and the hospitals don't have to pay for utilizing the registry. So it's a big concern for us, but we are working together to find some ways to make the registries sustainable. And the other things that we have been doing is we are contributing to scientific evidence generation at the like a global platform as well. So we are part of the big trials in critical care like REMAP-CAP and MEGAROC. So they have the implementation of those clinical trials have not only helped us contribute to evidence generation, but they have built our research capacity as well. So we have been able to train our local stakeholders, the participants in trial implementation, supervision and monitoring, and lots of other processes associated with clinical trials, which wouldn't have been possible without the registry itself. And what we have realized that there are so many barriers when we talk about the research activities in settings like ours. So there are financial barriers, there are human factors barriers. We don't have like a dedicated research support team or trained researchers. The governance, the ethical, regulatory issues are always have always been very complex and very complicated in this part. There are multiple like barriers in getting the approvals and permissions for the much needed research. And the research environment and infrastructure are quite poor, and there are difficulties with patient recruitment as well. So there are so many cultural issues, the literacy on research projects. These have made the implementation of these clinical trials very difficult. But what NICR, the Nepalese Registry organization, has adopted is like with the availability of registry, we have been able to improve data curation. Now we have good quality validated data on our ICU patients, and we have been able to collaborate and learn from the experience of registries from high-income countries, and this kind of collaboration with LOGIC and other organizations have helped us build that capacity. And besides that, we have also been investing on training for our local participants, the stakeholders from different ICUs. Currently, we have 2 PhD programs that we are running through the registry. These projects are embedded within the registry, and we have MSc programs in clinical research as well. And we have been able to support these researchers to provide them the protected research time so that they can get out of their routine clinical work and help us implement these research projects. And this has been made possible through the registry itself. And besides that, this is where we started in collaboration with Critical Care Asia and Africa. So this is a timeline, and in the last 4 years, we have made significant progress in building the research capacity and implementation of research projects. Now we know our research priorities. So we did several exercises within the ICUs and across our network where we identified our research priorities, and we have been working on that. And so currently we are doing the clinical trials with quality improvement projects, and recently we got approval for doing our observation study in dengue as well. That is a big problem in this part of the world. So registry has made this possible in Nepal. And these are the 2 clinical trials that I mentioned earlier, and it has been very helpful and a good learning experience for us as well. And there have been lots of publications on how the registry is being utilized for implementation of these research projects and how they can be done in a resource-limited settings and without compromising the quality of the research projects themselves. And we have published the performance evaluation of our ICU data set and registries. And if you look at that, they're quite comparable to registries from some of the high-income countries. And we have been reporting on the quality indicators and the process indicators, the patient characteristics. And recently we published a paper on epidemiology of critically ill patients in intensive care units. This is a registry-based cohort study with almost 18,000 patients. It's the biggest study that has been done within our country and also in this part of the world. So this gives us a very a good idea on the burden of the disease, the characteristics of the patients, and the gaps that we need to work on to improve the patient outcomes. And we have also been able to map the ICU capacity of different provinces. We started with one of the 7 provinces of Nepal. Now we have the data on the ICU beds, the human resource availability, and different organ support that we are available within the ICUs in this province of Nepal. And we aim to scale up this to other provinces as well through the registry itself. And these are the participating ICUs. Now we have recently a few more ICUs have joined the registry, and we have reached 20 in number, the total ICUs within the registry. Besides that, I myself is a PhD candidate, and my PhD project is based on looking at the incidence, risk factors, and the impact of ICU readmission. And we're also working on designing an intervention and trying to look into the implementation effectiveness of one of the interventions that we have identified. And my mentors, George, Avi, and Rasan, have been very helpful. And I believe that the implementation of the registry has made this project very feasible. We have one more PhD program, and the person, my colleague, is working on following up the post-ICU discharge patient and looking at the mental health issues. That's quite a big burden also in this part of the world. So we have already started that project, and we have one more project on. One of our colleagues is working on doing MSc in clinical research, and that's a huge added value for building the research capacity locally. So I'm thankful to all my colleagues here in Nepal. So these are the team members from different ICUs, and I'm also thankful to all my mentors, supporters, all these people, and also the team from IDOR and CCA and the technical team from Sri Lanka. Thank you. So I end with that. And these are the contact details of our organization. If you want to reach out for further collaboration, you can take this further. Thank you.
Thank you, Deepesh, for your presentation. It was really nice and interesting. And now we will hear Gaston Burgui from Uruguay. Hello, Gaston.
Hello everyone. Yes, my name is Gaston Burgui. I'm an intensivist, a critical care physician in Montevideo, Uruguay. And it's a pleasure to share this activity with all of you. I can't progress the presentation. Well, Uruguay is a small country in South America with only 3.5 million people. We have a complex health system where public system and private system are connected. And this complex system is supervised and monitored by the health public ministry. Yes. We have a big problem with the information in the ICU. All the ICU, the publics and the privates, have different electronic database, different electronic history, clinical history, and information is not well structured, and then we can compare and we can have the same information. It's for that in 2016, in the Society of the Intensivists, with agreement with EpiMed, make the National Registry of Medicine, Intensive Medicine. This registry is optional, with a platform with structured information, and is free of every cost. Yes, for each ICU, an equal structured database was generated, and the ICU staff complete all patient data. In Uruguay, we have 51 ICUs. Of them, 16 are publics and 34 are privates. In this moment of these 51 ICUs, 24 make part of the ICUs Uruguayas, of the National Registry. For us, it's really important that the half of the units participate in this project actually. Over the years, we obtained data from 28,000 patients. For our country, this number that is very small for other countries is really significant. And it's really important that this information is available for all those who wish to analyze it. Intensivists or all the people. Yes, all people can access a website and see all the data of the critical care in the last years. And for us, that is really, really important. Here we can see how the variation of ICU inclusion year by year. Yes, 2 ICUs were included in 2016, and now we have 24 units, and we have near 300 beds. That represents the 50% of the beds in Uruguay, and that is really important too for us. How I tell, we have 24 units, near 300, and we have 28,000 patients with data year by year. Here we showed how the information is collected in a structured way. And this way is the same for each ICU that participate. It's very easy to include patients. We have the errors are minimized. Practically, we have not to include data typing. It's only clicking true or false or certain variables, but it's really easy to make. What's the benefits? The benefits, we can establish different levels of benefits. The first benefit is for each ICU that participates. Each ICU obtain their main indicators for their management. Yes. In this sense, we can see the occupation rate, epidemiological data about our mixed patients, the principles, diagnostics, type of patients, comorbidities, and different scores, the use of resource, yes, the duration of certain of these resources, the severity, the mortality, and the standardized mortality. In other step, we have the information for the society, the intensivist society, but also for the whole society, and is the aggregate data from all the ICUs with all data year by year with the same comorbidities, diagnosis, use resource, mortality, standardized mortality, and this is really important to know. It's important to know because we have no data before 2016, and now we have really a data, and we can make a benchmark with each of our ICUs. What are the future steps we planned? Well, increase the inclusion of the ICUs, generate local research, and participate in collaborative research. In 2016, 2 units were included in the registry. In 2023, we have 24. We want to reach the 100% in 2024. For this, we are working with the ministry, with the health ministry, to transform the national registry that is an according between the Society of Intensivists and EpiMed to make the registry in the tool management for the ministry. This is the easy way to reach 100% of inclusion very quick. National research, yes, we have to start to make epidemiologic studies now how the structure and the organization impact in our outcomes. Collaborative research with various sites, but I think almost that we have to work with the Ibero-Pan-American Federation. We are in the same region, we are culturally similar, we have probably the same problems, and we have not studies, collaborative studies, to know our mix of patients, our outcomes, etc. I think that this is the first step to collaborative research, and of course, research will participate in all studies that LOGIC is involved. Thank you.
Gracias. Thank you, Gaston. It's really nice to see the work being developed in South American countries. So now it's my pleasure to announce our next speaker, and our next speaker comes from Scotland. It's Naz Long, who's going to present us the experience of the Scottish registry in the next minutes. So Naz, please, the floor is yours.
Thank you very much, George. I am just going to get my screen shared before I kick off. And George, are you able to just confirm you can see that okay?
Yes.
Great. Fantastic. Well, thanks very much for the invitation to share some of our experience in Scotland today. My name's Nazir Lone. I'm chair of the Scottish Intensive Care Society Audit Group, which is the name of our registry. I also work in the hospital here in Edinburgh as an intensive care doctor, and I also have an academic position in the University of Edinburgh in the Usher Institute. So just to give you an idea of the scope of the Scottish audit, we're a country of around 6 million population, and we have roughly somewhere between 35 and 40,000 admissions a year to our critical care units. And in the UK, we classify critical care into two broad levels of care. So one is intensive care, and that's basically mechanical ventilation or 2 or more organ support, and then high dependency units. And those are people, for example, receiving just vasoactive support, but without mechanical ventilation, or non-invasive respiratory support, or renal replacement therapy. So that's how we structure intensive care in the UK, critical care in the UK. And we have all ICUs captured in the audit, and almost all high dependency units. Scotland has quite a lot of rural areas and islands, and it's just 1 or 2 of the very small high dependency units that don't consistently contribute. So we have 100% ICU patient capture, and actually in terms of patients, 99.9% of HDU patients, because these units that don't contribute to the HDU part are actually very, very small with very, very low activity. So broadly, we, like many of the audits presented today, we collect data on activity, organ support and interventions and outcomes. And we provide monthly reports back to units to ensure audit data quality and give them feedback on performance against our measures. And then every year we'll publish a fairly comprehensive report about activity and quality of care in Scottish ICUs. And that report is always unit identifiable, so that the public can also judge for themselves, along with government and policymakers, what the care is like in their local units. So our overarching aim is really that, yes, we collect data, but the primary driver is to improve the quality of care and ultimately the outcomes of patients in critical care. And we use data and try and link it into a quality improvement cycle, so that, and we have a series of quality indicators and minimum standards that are developed with the critical care community in Scotland, which we measure practice against. And breaking that down into more specific objectives and the processes we need to do to achieve those aims, clearly one of the things, like many of the audits, have to maintain a very high quality database with regular validations and training in units to ensure that data are consistently collected accurately. We have a quality indicator development process, which is currently, we're just currently in the middle now of updating the minimum standards and quality indicators for Scotland. We report units that are outliers in terms of performance or not meeting national standards. And then most recently with the pandemic, and I'll touch on this at the end, we have tried to make sure now our systems are developed in a way that can report rapidly on a daily basis activity if needed, for example, during the pandemic. So just a bit of the history. So we started a long time ago, 1995, and it was really some very, very enthusiastic clinicians in a few of the larger units. It was very much owned by the Scottish Intensive Care Society, which is our professional society in Scotland. But the way these things happen with enthusiasts, there was no money, no funding, and trying to keep the audit running was challenging. There was initially a grant, a research grant they obtained in the 90s, but ultimately in 2006 a decision was made to embed the audit into the National Statistics Organisation for Scotland, and that now is called Public Health Scotland, which is where the audit still sits. So just moving on to some of our core business. So every day across Scotland, clinicians, doctors and nurses will be interacting with the data collection system multiple times a day. And the report we produce is available. I'll put the link at the bottom of the screen there every year, and the reports going back to 1998 are available on the website as well. Like many other audits, we have a range of process and outcomes we report. Here is a funnel plot. You've seen a few of these as the day's gone on, showing mortality. The letters there are all identifiable. There's a key. You can look up what each unit is and where it sits relative to the Scottish national average using the Apache system, but adapted for Scottish data. These are reported by many different registries around the world, but readmissions to ICU within 48 hours, delayed discharges. So we have a standard of when someone's declared ready for discharge, they should leave the unit within 4 hours. And you can see this is a huge problem currently in the UK and Scotland as well. More than the blue line in the middle there is the Scottish average of 50% of patients are not discharged within 4 hours. As I mentioned already, our quality indicators are a core part of the audit, and we report these as a sort of traffic light system with units that don't, and this is the important bit, that don't actually meet standards, need to provide evidence, comment and evidence of what they're going to do to try and meet those standards, so that there's a continual drive for improvement where we find units aren't meeting our national standards. And we have a slightly different set of standards and indicators for the intensive care units and the high dependency units. We also do an annual census to record the number of beds that are actually funded across the country, the number of nurses that are available as well, the level of training those nurses have in terms of critical care specialization. And this year we've expanded that out further to capture, in recognition of the wider MDT that you need to run a critical care unit. That's now expanded out to include staff involved in ICU rehabilitation and also in ICU recovery services. The units monthly reports they get, that's just so that they can see on a monthly basis how well they are meeting a select group of standards and indicators. This on the chart here is an example of a QSUM chart, which gives an early warning system for units rather than waiting at the end of the year to find out if they're an outlier for mortality. This you can see where this blue line is drifting upwards, then hits the dashed line. That means that there's been a consecutive sequence of patients who've died with relatively low predicted mortality. And that's meant to help the units start investigating and looking before the end of the year to see if there's anything that's happening within their unit, or they have data quality issues crept in, which is often one of the primary drivers for that. We also collaborate with the hospital-acquired infection specialists in the national bodies in Scotland to report HAI surveillance. That's ventilator-associated pneumonia, catheter-related bloodstream infections, and bloodstream infections generally. That was suspended during the pandemic, and we've now restarted collecting and reporting on that too. And then just a few things that may be slightly different from other audits. Over the last few years, we've started collecting data in maternity high dependency areas. It's probably a stretch to call them units themselves, but and they've developed their own indicators of quality, for example, like babies and mothers not being separated. And that's more of a novel aspect of our audit. The other thing is that we actually sit within a stable of national audits in Scotland coming under the Scottish National Audit Programme umbrella. And those are the current audits. You'll see that includes trauma and stroke. What that means is there can be shared learning in terms of processes of how do we develop indicators, how it's best to measure them, are there ways of rolling out training that's best. And then also, obviously, the resource from a Public Health Scotland side, that means analysts can work across different audits and share learning and coding and generally have efficiencies. And the last thing, which is a bit different perhaps in Scotland to other areas, that we have a very well-developed national data infrastructure and unique identifiers for each patient. So every time a patient comes in contact with a health service in Scotland, which is broadly a publicly funded, publicly delivered system. They get a community health index number, a CHI, and that is trackable throughout their all of their contacts. You can see these are the different data sets available, collected from routine contact with the health service. Very similar to a lot of our Scandinavian colleagues, the way the health data recording is set up. That then, for us mainly, but for research purposes, you can access that through going through a process. For our audit, we generally are focusing on the Scottish Death Registry and the acute hospital admission data set, because they're very useful for imputing missing data in our data set, and also allow us to look at long-term outcomes as well. The last bit is really to understand the political landscape in critical care, and that is we sit and work very closely with the National Society, the Scottish Intensive Care Society, and really importantly, the delivery group. So that is the medical managers of each unit in Scotland, the forum that meets there. And the three organisations, each of us who chair each organisation is co-opted on the other organisations. And that means there's a constant communication channel of the three key parts of delivering critical care in Scotland. So I'll finish off just by some of the rapid changes we made during the pandemic, because I think that's probably one of the highlight areas. So we switched from this monthly system to a daily reporting system, and got reports out rapidly to all the key stakeholders, as well as these regular, more detailed reports for the public. That meant we were able to report activity like other areas have been able to, but we again were able to link with the laboratory data. So everyone who'd had a PCR positive test for COVID, SARS-CoV-2, we could pick up in our data sets and then just report. Early signals that it was more socially deprived areas that were more hard hit. And we were able to track the organ support change of how we managed things in the pandemic, where at the beginning, most people were being mechanically ventilated. That dropped substantially in the second and subsequent waves. And similarly, organ support for renal replacement dropped off. Importantly, we needed a system to monitor when units were going over capacity, and we were able to do that. And again, highlighting units serving more deprived areas in Scotland were particularly badly impacted. And because of the linkage to the death registry, we were able to report single time point death, like 30 days rather than hospital discharge, but also longer term outcomes. So these are out to about 6 months of death after admission to ICU or HDU with COVID-19, and the risk of hospital readmission subsequently. The other thing we're able to do, because we're relatively small and agile, is pivot very rapidly for where there's a need. And we found since the pandemic wrought its path through ICUs in Scotland, it's been very difficult to retain nursing staff. So this was a point prevalence survey we were able to do very rapidly on single day, 13th of January 2022, showing just how problematic nurse staffing now was within units. So rather than this going through the electronic data entry, this is a very rapid, each unit being able to be contacted saying, give us a sense check today of what's going on the ground. And it's that sort of power with information like that, which can really feed into the political debate and policy and allow us to influence things at a very high level. So I'll finish then. The key thing to acknowledge is there are 3 core members of staff only in SIGSAG that keep the whole show on the road. That's Ros Hall, who's the clinical coordinator, Helen Watson and Danny Walker, who's the analyst involved. And a lot of the figures I've shown from our report, and that's the group who wrote those reports. And I'll finish there.
Thank you, Nasir, for your presentation. It was really very interesting. And now we can hear Mariam Shamal Ghalib from the Afghanistan Registry of Intensive Care. Then we will do the question and answers for this section. Are you there, Mariam?
Hi, everyone.
Hi.
I'm just trying to share, but something happened. I'm so sorry. Let me just, I think I'm still not able to share for some reason. I did share during the test, but I don't know why am I not being able to share it now.
Don't worry.
I'm so sorry for this.
Hello,
problem.
Dr. Mariam. Can you hear me?
Yeah, but when I want to share on the Windows, I don't see my presentation.
Do you want to see the bottom, share screen?
Yeah, I did go there, and my presentation doesn't appear here now.
Your presentation is open in your computer?
It is open. Yeah, it is open.
It's strange. Try to stop trying share and try share again, please.
Okay. Okay, let me try once again. Okay.
Oh, now yes, perfect.
Hello, everyone. First of all, Bismillah ar-Rahman ar-Rahim. And I'm Dr. Mariam Shamal Ghalib, and I'm from Afghanistan, and I'm the country coordinator for NICC, and the registry that we run there is RECA, which is Registry for Intensive Care in Afghanistan. I'm also the CEO of MINA Social and Health Services Organization, and sometimes I just want to put my other hats on, and I'm also the CEO and the founder of This Style, which is a project to empower women in Afghanistan. During this presentation, I will be first talking about how RECA came into being, and then currently the status of RECA, and also our scope of work, the challenges we are currently facing, and also I would love to talk about some of the opportunities that we can get a helping hand from those who would like to help the healthcare system in Afghanistan. First of all, during the pandemic, obviously, before that, I would like to tell everyone that RECA is the first registry in Afghanistan. So it's not something that has been there before, and people are not familiar to this. I remember talking to the minister with the previous government that we are setting up this registry, and he was like, "Why don't you set up a registry for one hospital and then focus on all parts there?" So the idea is quite new, and it's difficult to actually get people to understand it, especially the government officials. And with the change in the government now, it's a lot more difficult. So during the pandemic, the group of young doctors that was around maybe 100 or more than 100 young doctors who came together, and we noticed that there is some lack of medical expertise and lack of equipment. For example, during the pandemic, we noticed that people were that the doctors in the hospital, they were using a CPAP instead of ventilator. So we didn't have equipment, and it caused a lot of preventable deaths. Due to these problems that we were facing during the pandemic, we reached out to Abby and Rashan from CCAA, who are very kind and obviously understanding and also motivating personalities that I came to know. And they encouraged me to work on this registry and start working on data, and then the data can be used to identify gaps and then improve the services. With that, I had to start that. I did start that, but obviously we couldn't do it independently. So we had to work with under an organization. For that reason, I registered a minor social health and services organization with Ministry of Economy and also Ministry of Public Health, which was not very easy, as in some of developing countries. It's a very difficult process. It takes months and almost an year to register with one of them, because you have to go through all the formalities and there is no proper roadmap to take you there. So we managed to do that. And recently, but with the change in the government, obviously everything changed, and we had to pause the activities for registering the project with those entities that are responsible, the authorities. So we managed to register RECA with Ministry of Economy last year, which is the procedure there that you have to register it. And also we managed to register it with Ministry of Public Health recently. And currently, as I didn't mention that I was in Afghanistan, but currently I'm in UK after the evacuation and the change in the government, but I'm still running the registry. So I had to travel to Afghanistan just to sit on the same table with Taliban and obviously present my project and defend my project. And obviously just against my expectations, they were very supportive, and they said that you can put a team together with different bodies inside the ministry, like those who are working on research, research committee, and also HMIS, which is for data collection and all that, and critical ICU. So they offered me to make a committee, which we are working on to start. I just wanted to mention, just share some pictures of the efforts of Afghan young doctors during the pandemic. We started with packages of food delivery to people, then moving to distributing PPEs. And this is a picture from the biggest maternity hospital in Afghanistan, which we took some PPEs. And this is a picture of like donation of oxygen balloons that we were lacking. There was lack of oxygen, there were no balloons. And this is the hospital, which is actually one of the biggest hospitals dealing with infectious diseases. And they were not even having pulse oximeters and PPEs and oxygen balloons. So we raised fund actually quite. It was very less, but at least we did our part. So we started like there. So currently with RECA, we are the scope of work is to gather data, collect data, which can be used for service improvement and research. And currently, the data is being shared with some of the hospital management teams who ask for it, and they do have access for it, but we also provide them with the reports. And we also would like to promote the culture of research in the medical field, which is very, very weak. Like currently, some of the researchers are taking the baby steps to start research, and the interest is a big problem. And then we need to guide and train new researchers. This project, we have planned to do it in 3 phases. The first phase is setting up the registry, which we did with the help of CCAA team, Abby, Rashan, Chamera, and everyone else on the team who are currently helping us. And we managed to connect 13 hospitals. These are mainly public hospitals, but we also have some private hospitals. This is being implemented in 3 provinces out of 34 provinces in the country. We do have the capacity to expand it, but we are waiting to start the second phase so that we can then so that we are able to use the data and not waste any resources. And currently 40 ICUs are connected, 5 of which are currently inactive because they were mainly for COVID patients, and also some ICUs were shut. So, and we have 17 data collectors. We are currently sharing data with the hospital's management on monthly basis, and the aim is to get them to look at the data and then analyze the gap in the care of the critical care patients, which is something difficult to implement, obviously, and get them interested, but it will take time, and obviously to build any culture, like it takes some time so that you get to what is expected, and then subsequently that will help them to improve their service. This is a screenshot of our current registry, and currently we have 18,000 patients there, and then 35 active ICUs and 13 hospitals, as I mentioned. And as you see, Afghanistan is on the map. It looks like it has a lot of areas that are not covered by our network, but inshallah, hopefully we will soon be able to get more ICUs involved. And one of the problems is that there are not much ICUs. They are mainly embedded in the internal medicine department, so we don't have anything specifically for as an ICU department. So currently we mainly activate in Kabul, and then we have a few ICUs connected from Herat and Nangarhar as well. This is a picture of our very dedicated data collector, who is also a physician at the ICU in Jalalabad, and he is very committed. I just wanted to show his picture. He also attended the ICU for data entry on the day his daughter died. So we have very committed team, and hopefully we can make it. And during the second phase, we actually would like to set up a research training center where this data that has been gathered can be used, and we managed to also bring on board Dr. Saib Awab, who is also a senior researcher at Moro, to come as a volunteer and train those physicians who are collecting data, and also those who are not collecting data, but they are interested in doing the research, so that they can be trained properly on how to do the research. And also during this phase, the data that we have collected, we want to make some good use of it, and it is easier to get approvals for researches within the country. So it is good. And also this setting up this research center will help us to make a roadmap for doing a research in Afghanistan. Obviously, with the cooperation and the coordination of Ministry of Public Health, because they don't have anything currently, and it was mentioned during the presentation that I had. They said that they didn't have any roadmap for it. So we will be trying to work on that one. You may have noticed that for Afghanistan registry, it is like baby steps. We are trying to take very small steps, but I think it is going to, inshallah, have an impact in future. Unlike other registries, mashallah, they have achievements, but we are still having a problem dealing with the different formalities in the country, change in the government, and nothing is stable in the country, and we are trying to survive. And during the third phase, we would like to expand a research training center to become a research center maybe in future, and also one-stop shop, like those researchers from different parts of the country, especially from underserved provinces, if they are interested in doing some kind of a research on critical care patients or any other patients, they could just get to us, and we can provide them with the roadmap, and also also help them with the process, and also maybe serve as a portal system for them so that they can send us their papers, and we can just go through the formalities and send them back, so that it makes the process easier for them, and it is somehow encouraging for them. There are challenges, obviously, with the, first of all, there is a lack of interest in doing research, because this research is not a new thing, but in Afghanistan, with the change of government and level of literacy, and also the difficulties that they have been facing, and also the mental stress that is continuously there. So there is some lack of interest in doing the research. And also we do not have inadequate number of ICUs, as I mentioned, because especially in those underserved provinces, we don't even have an ICU. I remember one of our focal points during the pandemic said that we receive patients and from who are suffering from COVID. We also have traffic accidents there, but we don't have an ICU, although it is a hospital by the highway, but we don't have anything. So we do have this problem throughout the country. And then there is inadequate expertise in the field of critical care and also research. As a resident in Afghanistan in general surgery, I remember that like Wazir Akbar Khan is the only and the biggest trauma center for the whole Afghanistan, and then we don't, no one there knows how to do a central line or something. So there is some basic things that needs to be taught in the critical care, and we need support with that, obviously. And a lack of adequate training in research, as I said, that it's not very common. That's why we don't have adequate trainers or facilities where they can get trained. And ICUs are not independent units in the hospital, as I mentioned earlier, that they are mainly embedded in the medical wards. So it is difficult to get things done the way you want to. For example, if you want to add them to the ICU, to the registry, you don't only have to deal with the ministry and the hospital. You also have to make talk to the internal medicine department so that they agree and they let you start work. And also there isn't any clear roadmap for undertaking any research in the medical field. I just wanted to share this picture and show that the healthcare system in Afghanistan currently is that we only have the structure. We need staff training for it. We also need the staff themselves, because obviously there is burnout on the staff, and there are some traditional shifts, like you start one morning and then you end the other day at 4 o'clock, which is, I think, 36 or so many hours. So it is difficult. We lack staff, and also, as I mentioned, that we need training in the basic and advanced critical care skills, which is very, very important in the ICUs, on how to use the ventilation, how to take a central line, for example, intubation. And I remember during that pandemic from Afghan Japan Hospital, which is the only the biggest actually infectious hospital, they were like, we don't have the staff to intubate. They don't know how to do it. So they were watching YouTube videos and trying to intubate during the pandemic. You would imagine what kind of a crisis was that. So we do need help with this one. And also one of the problems is that we don't have guidelines for ICUs, not in that we have in other departments, but specifically because here we are talking about the ICUs, we don't have any guidelines for treatment of patients in ICUs. I remember that I talked to my teachers in the medical field, like to bring them around the same table to draft some guidelines during the pandemic to treat the patients, but I was not able to do that because for some of the reasons they were not coming together. So it is another challenge, obviously. So if it comes through someone outside the country, it might be easier to get those doctors around the table. And because we need help with everything, one of the things that we do need help is that mentoring the new researchers, those who are interested. They always ask. I just tell them that are you interested in doing research, and you can provide you with the data and this and that, and they are like, is there anyone to help us, to mentor us? So we do need international mentors as well. And because of the skills that the physicians in the critical care units need. So we, if there are some kinds of obviously scholarships for them to get trained, even if it's online, it is a great opportunity for them to build their capacities. There is lack of equipment, and also if telemedicine is something that we have always thought of, like creating a group where we can have international doctors, and then we have our critical care practitioners there, or physicians who can just maybe leave their case notes and the problem, and then they get advice from the international doctors. I can talk hours and hours about the healthcare system in Afghanistan and the problems that we are facing. And as a trainee that I was there, I have noticed so many problems, but because the time of the presentation is less and it's out of the scope of the presentation, so I would stop here. And if anyone wants to talk about the presentation or any of the aspects, and also if they are interested in helping the Afghan registry, RECA, they can get to me via the email address, and also this is the same number for my phone and WhatsApp. And thank you all for listening.
Again, congratulations for the presentation. Not only very impressive, but also moving in several ways, because it makes us reflect a lot about what the purpose of this meeting is to understand international differences, but also to see things from different perspectives and learning from each other. Big learning here, so thanks a lot. I'd like to ask the speakers that participated in this second session to join us online here. We have some time for questions and answers. Pilar, do you want to start with the questions and answers? We can't hear you, Pilar.
I was mute, sorry. No, the presentations were all very interesting, and really there are a lot of questions to do the different speakers. But if we see what the audience has asked, perhaps we can ask them, how do you do or how do you think you could do to extend your registries all upon the whole country, if in the legislation and also in the importance given by the governments to this type of registries. I think each can have a different perspective. if anyone anyone can
pick one of it. Well, I mean, I guess from our perspective, we already have complete national coverage. So that's, I guess, if I was to think about extending the audit, our key priority is really to move beyond just counting these metrics and be far more clearly embedded in collecting data which directly drives improvements in care. So, you know, obviously it's important to measure mortality, but for very clear direct improvements in care, there are other things we really do need to be measuring now, and they're more challenging to measure. And we've learned a lot actually from Dave and Nicolette and Nice, who are very clearly have already started embedding some of that practice. So yes, that's our key priority in Scotland.
Sorry. In Colombia, I think the one of the biggest challenges is the manual collection of the data. We have a very different electronic records, and not all we can integrate the tool that we are using to the electronic system of the hospital. But I think we are very confident that with the motivational approach, we can extend this to the highest, the biggest part of the ICU hospitals.
Marian, comments?
Yeah, in Afghanistan, as I said, that we are facing a lot of challenges, and what I find very effective is involving the government itself. So during my last meeting for presentation, and also I had a separate meeting with the head of all of the departments, I found that they are very open and they are happy to collaborate. So if it comes from them, obviously it's easy to be implemented, and we can expand the registry quicker, inshallah, and maybe throughout have ICUs from all the country, all over the country.
Gaston, Uruguayan perspective.
Yes, we are working with the Society of Intensivists, and if the government take the registry a tool, his tool for management, and for now to know the reality of intensive care, it will be easy, because the government can define that all ICU must participate in the registry. If we can do that, well, we have to work hard in Congress and meetings, convincing the different ICUs. But I think probably this is the way.
So I'll make a comment here that is related to this topic, but also somehow related to the other sessions. And maybe you can give your opinions about it. So I think that, of course, we're very biased here because we all believe in the power of data and registries, otherwise we would not be here today, either presenting or attending. But I think that we're not very good at selling this to the government or to the stakeholders, and even to our critical care community, and even to the researchers doing research in critical care. So if we look, for instance, at what the evidence-based medicine pyramid is, you have the RCTs, everything on top of it. But actually, this is the pyramid is maybe the tip of an iceberg, and below is real-world ICUs, real-world data, what's actually going on. And when we look at presentations from the last session, lots of the trials that were enabled in critical care Asian countries, Nepal and Pakistan, were only feasible because they were embedded in the registry. Otherwise, it would either be lower number of patients and sites or huge amount of work and investment to do it. But this investment does not go to registries, it goes to the trials. So I think that we should improve the way that we pitch the registries, that we prove the importance of registries to the different stakeholders, government, medical societies, etc. People take it for granted that you have data to share on a daily basis during COVID. But when you're actually asking how to be sustainable and to expand, there's not a lot of, people don't get moved about this. So what do you think?
I can come in, George, and start off. So, I mean, I would maybe go back one step and say, I don't think people did appreciate what we could offer in the pandemic. And it was only when we were able to prove that actually suddenly we got the attention of key stakeholders. So we have definitely leveraged that attention to show them the gaps we have and what actually needs to come in. So my presentation is very much about the strengths of being part of a national infrastructure, but that also means we're competing for resource with all the other audits as well. And we're constantly required to justify our existence, because why keep on collecting data if you're not clearly demonstrating direct improvements in care? So this was one way we can say, well, yes, that is really important, but actually the infrastructure is really important. So if that wasn't there, you wouldn't have had this information every day. So I think there is something around that actually the function of the registry, the fact that data infrastructure is there, it shows you that there's a real necessity here from a public health perspective, and pandemics, yes, this is the big one that hit, but everybody's aware that this is going to happen again. So the infrastructure needs to be there, ready to go. The other side of it, you were saying about demonstrating its benefit for trial efficiency, I think that's true, and I think you're right. This two sides of it is, we show how great it is, the fact that we can actually make trials much more efficient and they cost less money to do. That's one of the big sales pitches to funders. But actually, what you really want is to say, well, no, we actually want some money budgeted in there as well to feed in. But then that takes away the big sales pitch of, here is your efficient trial design. Look, we've cut this much money off the bill because you don't need this many staff on the shop floor collecting data anymore. So I guess that double-edged sword of trying to make sure there is still money in there, because we do need money to keep on developing, and it's not going to come, even if you're publicly funded, it's not going to come from public funds when there's a huge pressure on reducing the amount of public money going into non-frontline facing services.
Pilar, any comments?
Yeah, I fully agree.
Hey, so if there's time, we're gonna move to the next session. I think that as we're on time, we may allow a short 2-minute break, just get water, stretch, and back in 2 minutes with the third session. Is that okay for everyone? Amanda.
No, I think we have some question here at the chat.
No.
Yeah. How did you manage to advance with the regulatory guidelines in Colombia to begin use the registration tool?
Good point. Go ahead, please.
To across the country, what challenge and advice you can share? Well, actually, I think we are at very beginning, and actually, thank you all. I'm learning a lot today, and at the moment we are working on an informative document with the research committee, but it's very informative because in Colombia, each institution had to comply with the data protection laws of the country, respecting two fundamental requirements. The first one is that personal data arrives anonymously on the platform, and that the contracts are signed between EpiMeds, that's the tool we are using, which provides the tool, and each hospital saying that this data belongs to the hospital. I think that is the 2 points that we have to respect, but each hospital is independent to start to contribute with the national registry.
Okay. So 2 minutes and we're back with the third session. Thanks everyone for the great presentations, great learning. Marian, we'll get in touch, that's for sure.
Thank you.
Okay, so quick break, 2 minutes and we're back.
Cheers, George. See you in 2 minutes.
I think.
George, I can see you're back.
Yes, ready to go.
So we've heard some amazing talks from people, and registries at very different stages of their development and very different experiences. It's 11:30 at night here in Australia. I can still see a number of Australians on the line, so thank you very much for staying. Thanks everyone for their input into the talks. Thank you for your questions and for your interest. We've got 4 more speakers and we're going to be having questions and rounding up at the end. The first speaker that I would like to introduce is Edelon, who will be talking about the Brazilian registry. Before we started this morning's Logic Day, Brazil's registry in its embryonic stages, George was explaining to me how important Edelon was to the start of the registry. So it's a real honor to hear him talking now about their experiences. So over to you.
Okay, thank you, David. I'm very happy to be here, and I would like to congratulate David, Pilar, and Salluh by that very nice initiative to promote that meeting. Can you hear me?
Yes.
Yep.
Okay. So, in the next few minutes, I will talk about the UTIs brasileiras as our epidemiological registry, no conflicts of interest. So Brazil is a big country, as you know. Our population is 200 million people, and we have 44,000 ICU beds. And the relationship between beds and populations is like 20 ICU beds to 100,000 inhabitants. It's a very good number, but we have some problems because that beds have some problems about the distribution to assess the population. The UTIs brasileiras started in 2010, 11 years ago, 30 years ago. And when we began, our challenge was to have reliable data, to be known as a source of research of high quality, research about the real life, as have told us Jorge Salluh. And I think the most important objective for us was to be a driver to quality improvement. I think it's important for us in Brazil because our specialty is totally related to our results to the quality of your organization and process, as you know. So right now we'll have 22,000 ICU beds participating in registry. It's representing half of ICU beds in Brazil. I think it's important to share with you, especially with some registers are in beginning. It's not too easy the first years to motivate the people to participate in the project, but you can see in that figure during the years it was increasing each year. And right now we have almost 5 million of data of admissions patients. In that year, our expectation is to have almost 1 million of admissions in ICUs in Brazil, a lot of data. So I will try to explain in a few minutes some complexity about the health system in Brazil. As I told before, half of ICU beds are to population of private health insurance, and another half to people using the public system. So one problem is the only 25% of the population have access to private insurance. This part of population using half of the beds, and the another 7.5% of the population need to use the public system. It's a very important problem about the equity, the access to the system to people with use the public system is more complicated. Another problem in Brazil about the distribution of ICU beds is a regional distribution. As you can see in that map, in red are the regions of with few ICU beds. The north of Brazil is a region more poor in the country. The south region is more rich, and that's the second problem about the ICU beds distribution. The first is the access to the private or public beds, and the second is the heterogeneity about the distribution of that beds in the country. So some of that should explain in that slide the very important difference in mortality when we compare public and private ICUs. In blue, we have the mortality in public ICUs, and orange, the mortality in private ICUs. But when you see only the more severe ill patients, like the patients under mechanical ventilation, that difference in mortality is not the same when we see the mortality in general. Probably because in private hospital have a lot of patients with less severity of ill. Of course, the public hospital have more problems about the structure, organization. The primary care of health to people who use private hospital should be better. So we are a lot of questions to be discussed to understand that difference, but the use of registry is a very important tool to try to understand it. Another important role of the registers is to stimulate the research. Maybe the orchestra study should be the most important until now. The orchestra study was a multi-center continuous study of process, structure, and outcome of Brazilian ICUs. Initially, almost 80 ICU and 60,000 patients participated in the first study. Right now, we are organizing the second orchestra, the Orchestra 2, with the participation of more than 200 ICUs. And the aim of the study was to identify targets of quality improvement. And the most important results in the first study was the importance of the use of protocols to be ICU more efficient. It's important to change culture in our country. Another study or published is using the data of Orchestra 1. That's another study was about the importance of policies to open the ICU to family. And in that study was possible to show the ICUs with better performance, the number of hours with the presence of relatives in the ICU was most important than in ICUs with one quality inferior. Another importance of the data in real life is to show the impact of COVID pandemic in non-COVID patients. As you know, the pandemic was a disruption in our process, in our quality of care. And in this study, it was possible to show during 10 years a reducing of mortality in ICUs with an increase in 2020 during the pandemic. I think the most important result of this study is in that slide. In the superior part of that slide, in Vlad, it's visual. Its Vlad is upper. The result is good. If Vlad is down, the result is bad. In the inferior part of the slide is the number of admissions in COVID patients. In the part superior, the mortality of non-COVID patients. It's possible to see when the number of COVID admissions increase, the mortality, the patients non-COVID increase too. It was possible to prove the impact of the pandemic in the quality of our care. Another important point was to show to another intensivist and to authorities of health in Brazil the impact of COVID-19 to our population, and that register published by Amanda Quinteiros, we told us about the Colombia register. Different of you think before the pandemic, young patients represent a high percentage of the cases in Brazilian ICUs, and comorbidities and frail were important points about the outcome of the patients. Was possible to see during the time trends in resource using outcomes, was possible to see the impact of vaccination and reduce the admission of more older patients, because that population were the first to be vaccinated. And another important tool in the project of UTIs Brasileiras is the certifications. AMIB and EPIMED recognize the ICUs with the best performance. We use the KPIs like the mortality rate adjusted to severity and the rate of resources utilization. In that matrix, the ICUs in that tercile will be considered the top performing ICUs, and in the next year, AMIB and EPIMED certificate that ICUs as a top performing ICU. It's very important to know it's a competitive, because the number of ICUs receiving the certification is 1/3 of the total of the ICUs. And it's important to promote the improvement of quality in our ICUs. Every year, the people from ICUs waiting the visit of AMIB and EPIMED to certificate their ICUs. They are very proud to receive that certification. To the future, I think the most important for us is to increase the studies based in our platform. And another point very important is to participate in projects outside Brazil, like LOGIC, and like the UCs Ibero-Americanas. AMIB is very proud to participate in that. Amanda showed that it's for us before. And right now you have 10 countries participating in the project. And right now the challenge is to promote the engagement of the ICUs in that country. And we hope in the future we can have data about the Latin America ICUs to share with you. So thank you so much for the opportunity to share our enthusiasm with this project. Thank you.
Thank you, Edelon. I've seen the program here, but I don't see our next speaker here online. So I'll take the liberty to make a slight change and wait for the connection. So we'll follow as programmed, and the next speaker will be María Fernandez from Argentina, who will talk about the SATI-Q initiative in Argentina. So Ariel, the floor is yours. Thanks again for accepting the invitation.
No, thank you all. There was an excellent experience to hear from all these registries around the world. We are achieving a lot and learning a lot. There were so many exciting and motivating and inspiring presentations. So we hope to to share our experience and to contribute to all this class. We are from Argentina, from the intensive care society. We are presenting our SATI-Q program, SATI-Q. We are now celebrating our 20 years of continuous registry. So we want to share the evolution and future and perspective from this program. Please, Pilar.
Well, just to start, we should say that the SATI-Q program was established in the year 2002, and its main goal was to optimize the performance of intensive care units in Argentina. How to do that? First of all, it was established a network for the prospective and continuous collection of quality indicators. This allowed to have a real-time view of how the intensive care units performed and how they were evolving over the time. A fundamental part of our initiative is benchmarking, so the collection of the data allows the performance of each intensive care unit with the others, and both the comparison of the unit over the time. A highlight of SATI-Q program is the voluntary participation of intensive care units with different levels of complexity and infrastructure. In this sense, we think it allows to obtain a representative and comprehensive picture of the intensive care unit in Argentina. Of course, the initiative is not only data collection, but also participating in SATI-Q promotes internal quality management and external evaluation. This ensures that we collect data and work actively to improve the quality of intensive care units. The process briefly is as it follows. Each unit that gathers the program receives software SATI-Q, which is the IT support. It's an open source distribution tool to collect data that is integrated into the healthcare administrative practice.
Pilar, sorry to interrupt, but do you have slides shared? Because we can't see if you do.
Yes.
No, we can see they're not shared.
Okay. If you see them now?
Yes.
That's good.
Well, I was saying or telling about the process of the SATI-Q program. I was telling that we use SATI-Q software for data collection, and this is an open source distribution tool that is integrated into the healthcare administrative practice. Using this data collection tool, we gather quality indicators that were predefined by the SATI-Q management committee and registered in a standardized format. When the committee selected which were the quality indicators to be monitored, we took into account their importance, their feasibility, and the workload that signified for the participating units, taking into account that they are manually entered and the persons that do the data entry are the same doctors or nurses that do the care of the patients. All of this allows us to have a central database with anonymized records of patients admitted to the participating unit, that these databases are sent once a year in an encrypted format, and using after doing data cleaning and unifying them, we construct the reports. one report for intensive care units of adults and the other one for intensive care units of children, the pediatric intensive care units. Also, each unit has the possibility to access their real-time reports. This is a brief evolution of the program in these 20 years from the beginning. As Arias said, in 2003, it was designed, it was built the first intensive care unit built upon data given by 28 intensive care units. 2 years later, in 2005, it was built the report for pediatric intensive care units. In that report participated 8 intensive care units. Then it was a necessity proposed by the participating units to have access to their data in an accessible way, so they could use it for local research, and that's why the SATI-Q was added with the we call Sistema de Consultas, and that is a query system that allows the export the data into an Excel format, so the units can use this information and analyze in the statistical programs that they are used to, that they know how to use. In this sense, in the year 2013, it was published the first multicentric publication. As most of the previous speakers told, it's an important, the publication of research studies is a very important point that makes people want to form part of the registry and to join. This first publication was the validation of what we call pediatric index of mortality 2 in Argentine's intensive care units, and then we followed this research line doing the validation also of what we called PIM3, the validation of PIM2 in Latin America, the prevalence of chronic with patients with chronic conditions in pediatric intensive care units, especially epidemiological research was done. In the year 2018, we gathered this consortium that it's led by the Massachusetts Institute of Technology, with the aim to design what is called a global open source of illness severity score, that is like Apache score or a model to predict mortality for adult intensive care patients with data from different registries of the world. The following year, we joined the LOGIC, and in the last years, 2022, we knew the importance of the possibility that the units participate without using the software SATI-Q, instead using their electronic health records. And so Ariel began to work in the interoperability that he will explain later. And in the year 2020, the first unit participated, sending an electronic data submission report, and it was constructed a SATI-Q resource in collaboration with Health 11.7 Argentina. This year, we also had a datathon using SATI-Q database organized with the University of Buenos Aires, the Faculty of medicine. The SATI-Q today, to make a summary, has a database that contains data for more than 200,000 admissions of patients in intensive care units of adults, participating units from all the country, as you see in the map, and represented 800 intensive care unit beds, public and private ones. If we talk about pediatric intensive care units, the database has 80,000 admissions, also from the different regions of the country, participating academic hospitals and pediatric intensive care units in their hospitals, most public than private, and representing 500 pediatric intensive care unit beds. In this figure, we can see the evolution of the number of units, adult and years, and in 2022, the registry sent most than on year 20,000 patients for intensive care units of adults, with 70 units participating, sending their data, and 53 pediatric intensive care units were near 10,000 registries. This allows the units to have the information about, for example, how mortality has evolved in these 20 years, observed mortality and expected mortality, both for adults and for children. In the superior line, you can see the for example, when COVID mortality increased, and also we see in the inferior lines how the expected mortality and the observed mortality change over a year in pediatric intensive care units, having near 10% mortality at the beginning, and now mortality in children is 4%, it was in the last year. Also, we can have the evolution of the characteristics of admitted patients as the age in pediatric intensive care unit, that we saw an increase of age of children admitted to the units in the last years, device-associated infections for pediatric intensive care units and adult intensive care units, seeing, for example, that ventilator-associated pneumonia is one of the main problems in both cases. And also, when we speak of collaborative research, as I told in the previous figure, there are a lot of research that was done using the software as a data collection tool in a prospective way. For example, the validation of pediatric illness of mortality scores, and retrospective data analysis for the last paper that was published that showed that socioeconomic conditions had higher rates of sepsis in children with similar outcomes, and also allowed to participate in the several studies led by LOGIC. At the future, we think that we should increase collaboration for research, identifying research topics related to epidemiology of diseases in critical care patients, patient safety, quality standards. Also, we need to specialize in data science, big data analysis, because some registries are beginning to work with artificial intelligence algorithms. In that sense, we should have management and generation of knowledge from local data. And then in line of the future, Ariel will tell us about the interoperability.
Is new for me, but this is the new challenge for all the registry of electronic data submission registry. That is why from Intensive Care Society we decided to move forward to a new focus, to a new strategy between two points. One of them is receiving data from electronic data submission form, so we can offset participating in this program, not using only the SATI-Q program. You can use any kind of electronic registry and send data in this structured format. And then on last years, we developed with HL7 organization from Argentina, an HL7 file resource, so you can bring the data electronically without any intervention of any human, between connecting automatically with the standard, the electronic health record system from the institution, and the SATI-Q program. So the challenge for the futures are a lot. We first and again want to thank the Intensive Care Society for their strategic vision 20 years ago to begin building this program. And the challenge for the future, of course, is to work with synergy and collaborative with other networks. The experience being told in this presentation from all the countries blow out our minds to begin to work and create a new networks and collaborative to future research. So interoperability can allow to extend this participation and create this new collaboration studies, data culture, data quality, education. Well, the challenge are big and maybe the same as all the part, but a few words noticing Afghanistan, a great from Argentina, from our hearts. We hope to move forward and to have some way to collaborate with you and move forward on that country also with intensive care units. So thanks for all.
Thank you, Pilar. Thanks, Ariel.
Thank you.
Great to move ahead with the next presentation, and it's my pleasure to invite David Pilcher to talk about the Australian-New Zealand experience. Dave, please.
George, thank you very much. Can you guys see my slides?
Yes.
Excellent. It's been very interesting hearing how many similarities, but also how many differences that there are between our registries and our experiences with intensive care in our different countries. The ANZIX registry is 30 years old this year, so we are a little bit younger than the Italians, a little bit older than the Argentinians. It's a registry that covers two countries, both Australia and New Zealand, and the two countries have a common history, but they also have a common training scheme and common, very similar healthcare systems. Not exactly the same, but similar. But the intensive cares have to cover very different geographies and very different regions and very different populations. Along the eastern seaboard of Australia, we have very large, highly industrialized cities such as Melbourne and Sydney. Melbourne, where I work, has very big ICUs. The ICU where I work is 60 beds and provides services to a hospital that has all major services. Where my colleague and friend Paul Seacombe works in the middle of Australia in Alice Springs, he has a 10-bed ICU that provides services to a population of about 50,000 patients, but those 50,000 patients are spread across an area that is approximately equivalent to France and Spain combined, or twice the size of Ukraine. So the ICUs and the hospital systems have very different experiences. And then we have New Zealand, which is a very mountainous country, a highly developed country, an incredibly beautiful country, but the geography and the system brings with it different challenges. But we have them, all of them, feeding into the same registry. The registry covers approximately, it's almost universal coverage of Australia and 2/3 of New Zealand, but it's grown from very humble beginnings. The pictures that you see here are of the individuals who started the registry 30 years ago. And in the bottom right-hand corner are the 4 men who were the computer interest group for Australia and New Zealand. And this is them standing around the computer that was the first data collection system that became an access database, that became the registry, that was led then by Graham Hart, and now was the forebear of the system that we have today. And that's them hiding at the back of an ANZICS conference in 1993. Our registry has grown over time. We have adult and pediatric ICUs. We also have mixed ICUs. The pediatric ICUs are the blue ones on the top. The mixed ones are the dark ones in the middle. And the database started in 93. It brought with it data from other hospitals. We started surveying sites on an annual basis a few years later. Pediatrics came on board in the late 90s. But it wasn't until the early 2000s that we started doing routine automated reporting to sites. And really that is when I think we became a true registry, benchmarking practice, comparing outcomes, and starting to compare processes of care and resources as well. And it wasn't until shortly after that that the first publication came out of the registry. So the registry's purpose has been from the beginning very much a safety and quality exercise. It is not the purpose, the focus of the registry to do research, although we like to facilitate that. And as soon as we're benchmarking, then we've had to develop a system for managing, analyzing, and appropriately reporting outliers. It wasn't until the 2014, 2015 that we introduced our own risk adjustment mortality prediction model. And this is the basis of the mortality benchmarking that we have. And it wasn't until just before sort of 2017 that the access database that was produced by the 4 men who you saw in that picture at the start of the presentation was replaced by a much more sophisticated data collection system that is now used by the majority of hospitals. That didn't happen until just a couple of years before the pandemic. What we have seen, though, and the shaded area is the number of patients that are reported to the registry each year. This has grown progressively over time as ICUs have not only increased their reporting to the registry, but ICUs have grown in size. And essentially, how we function now is very similar to some of the other registries. We have individual patient data, and this feeds into an online reporting system where there is secure, curated, restricted access where people can see detailed reports about their ICU compared to a benchmark, compared to a peer group. We survey ICUs on an annual basis, asking them about their resources, their processes of care, their safety and quality metrics, their staffing, their medical staffing, nursing staffing, allied health. And each of that is reported back to the registries in a similar way to the way in which Dave Dongelman's described for the Dutch registry, with the aim of not only benchmarking outcomes, but benchmarking processes of care so that sites can see how what they do and how they deliver care varies. And with the pandemic, we also now have an operational daily dashboard activity system called CRIS, the Critical Health Resources Information System. And this allows us to see how busy individual ICUs are on any one day. And this was actively used when Australia, which was affected by the pandemic relatively late, it wasn't until sort of late 2021 that we really experienced a lot of what the rest of the world did. But we use the system for active load balancing And now this is part and parcel of the sort of the landscape of intensive care in Australia and New Zealand. And it gives us a clear picture of Australian and New Zealand intensive care practice. It's a population of about 30 million. We've got 220-ish adult and pediatric ICUs, some closed, some open. That's about the number. 2,600 staffed ICU beds. So that's actually per population a lot less than some of the countries that you've seen. But for us, an available ICU bed means that that's one-to-one nursing staffing. And this translates to 220,000 adult and pediatric ICU admissions per year. We create public reports. We are not funded for research. We do, however, make our data available to researchers. And if researchers want to then go away and work on it, and I include myself as someone who does that and supports other people to do that, then the data gets used for research. But we've set mechanisms to do this. And it's only in the last year or so that we've actually received funding to increase and adapt our infrastructure so that we can build true observational and interventional studies into the registries, because that's not something that we've been able to do prior to this. What we've done before this is actually provide data to researchers that then it allows them to leverage that or inform both the development and implementation of their trials. What we have done a few years ago, and this has been very important for us, and in some of the other earlier presentations, we heard people talk about how you use your registry data. This was an economic analysis of our registry, which showed that the outlier management process, so this is the analyses that we do when we have an outlier intensive care, that process in itself saves the healthcare system in Australia $4 for every $1 that is spent on the registry. That's a major part of the registry. It's not the whole thing, but this is an important information that we carry with us when we seek funding from the health departments. And our registry is wholly funded by the regional health departments of Australia and New Zealand. The registry also gives us a picture of how things have changed over time. This is the mortality for Australia and New Zealand. And you can see in the 90s, there's a lot of variability, but it's pretty static. And over the 2000s, there was a progressive decline in mortality. It continued in the first year of the pandemic. And then in 21 and 22, it rose significantly, almost to the level at which we saw in the sort of 2010, 11, 12 period. So we've gone back almost 10 years. And this is an impact, I'm sure this is an impact of the COVID-19 pandemic. And we saw Edelon actually describe similar effects on a smaller scale in Brazil as well. We're now starting to see that mortality come back down, but it's had a significant effect on our system. So what the future for us is further development, and we still have the issues of sustainability of our registry, but we have a lot of information on the immediate outcomes. What we're now looking for and looking to report back to the intensive cares is the longer term outcomes of our patients. We have our data linked to the National Death Index, and over the next year we'll be implementing survival plots that show people what the survival of their patients is up to 2 years after their ICU admission. And we can see that even the most reassuringly, even the most frail patients that we have are 50% of them are actually alive 2 years after their ICU admission, which I think is better than I would have expected. And the other major project being undertaken at the moment by the team is the implementation of patient-reported outcomes and experience measures. And this is a major development for a registry where the team have been working on in the background for 2 to 3 years. And we've now started a pilot that's gone live in 4 hospitals a fifth and a sixth will go live shortly in the next few weeks, with the aim of expanding this out to approximately 30 adult and pediatric hospitals over the next 6 months, learning from that experience, and then using those learnings to develop the same situation, to the same system, and implement it across the whole of Australia and New Zealand as part of routine reporting. So those are the sort of the immediate developments that are happening at the ANZICS registry. What I haven't put in here is the external developments and the linkages and the collaborations that are developing through LOGIC. And that's an important and progressively growing aspect of the registry that we benefit from, and I think collectively together would benefit from as well. And my final slide is just a thank you to the individuals who actually are the ones that do the work. This is the whole ANZICS team. All of them are on this slide. And I would highlight just 2 people in there. I'd like to highlight everybody, but Sue Huxton, who's second from the left at the top, and Shayla Chavan, who's second from the right in the middle, have been both the engine room, the drivers, and the controllers of the registry for over the last 10 years. And without them and the team that they manage, who are all there on the slide, none of the things that we've done would have been possible at all. So I'll finish up there. I'm looking forward to a little bit of discussion and questions, and I'll hand back to you, George.
Thanks a lot, David. It was a brilliant presentation. I'd like to invite the speakers from this last session to join us here. There are just a few questions, so I think that we can go through the question and then wrap up and have the summary of our meeting. So the main question here, I think, is related to Ariel, because it was during his presentation. It's how do you manage data validation and quality checks with interoperability tools, as most registry-specific data is not captured in the electronic health records? So good point. So Ariel, do you want to comment this, please?
Well, if you capture in electronically way, you have the guidelines that I share in the chat. So if you don't have any electronic register, you can use the SATI-Q software. So you enter data directly through the SATI-Q software that have the quality checks and validation. So all data is structured and verified. There is no any kind of manual entry. I don't know if that responds the question. That answer the question.
Okay, so
the person asking the question is one of the ANZICS people, and Ariel, you have described almost exactly what we have in Australia, where we provide software that people can use, and that brings in beautifully curated and validated data. The data that comes from the electronic medical records, it creates an efficiency in the data coming in. We have found that it doesn't actually increase the quality of that data. What it does is embed a problem if it's there that then can be harder to unpick.
Thanks, David. You are always our light on the horizon.
Great, thanks. So the question here that follows is about missing data on these when you have integrated versions, interoperability. What's your opinion on this?
Well, there are always missing data in any kind of study. So the way we treat missing data is first balance how much missing data and in which variables. We don't impute that values. Maybe if they are extreme values or missing data, we extract that information from the final report, and we advise the specific unit to correct that data.
Any additional comments? David?
George and other speakers, I've actually got a question for you guys. I mean, other people have mentioned this. We have data. We have beautiful reports. We have people in countries that have been undergone huge amounts of turmoil. We've got countries that have well-established intensive care registries, and all of us seem to have similar problems getting, developing and using that data in a way that engages people. How do we collectively work to sell the stories of what we're doing? How do we make people engaged so that they can see the value of the data that we collect?
Great question. I think the first step is to involve and to get engaged with the Ministry of Health, the government, the politics. We have to create some regulation and rule that use this data in favor of all the population.
I think that's sorry, go ahead.
I have one comment. Oh, sorry.
Pilar, please,
Pilar,
go.
ladies first.
No, thank you. No, I was thinking that first we need to give feedback to the units, and not only to the units in general, because our process, for example, is that the report is sent to the contact of the unit, who is the responsible for data, responsible for the quality of the data that enter the system. But we know in the daily practice that usually not happened, and at the end it's are the more junior doctors that are the ones who collect this information and then enter it in the system, or the senior enters in the system, and these persons change. At least that happens in our country. I don't know if in the other is the same. And we see that sometimes the data or the results of this information doesn't arrive really to the persons at the bedside of the patient, who are the generators of the information. So we need to create data culture in all of the members of the intensive care units, and this will give us for better results, manually entered or electronically taken from the infusion pumps. But if the nurse knows that the information that she's entering, yes, will have a result, and that will give something better for the patient, we will have a more...
Yes, a two-way strategy, top and bottom, top government policy, and bottom bedside, the physician, the real uses of the data. So
I think slightly different. I think that in general, and I'm thinking from our local perspective, okay, I cannot speak for everyone, of course. I don't think we do a very good job in terms of making people understand the usefulness of data. So I think that when we talk about data, we're talking as if it was one thing, but it's multiple things. And the problem, in my opinion, is people look at things in silos. So people will look at reports as, this is management, and I'm a physician caring for the patient. Researchers will say, this is administrative data, I don't care about it. When it's research, clinicians will say, okay, that's beautiful in your trial, David, but you know, my ICU is a little bit different. So I think that, but I think this is an artificial division, because this data comes from the patients that are cared for the physicians, managed by the managers, and get enrolled in the clinical studies. So for me, it's all the same. And depending on how you pose your questions for management, you do a full research cycle. You have a hypothesis, you have methods, you have measurement, and you have how to show your results. So I think we don't do a very good job trying to put the pieces together for people to understand that it's the same patients, it's the same data, it's the same results, and that has different outputs that can be used for the clinical assistant, the management, the epidemiology, talking with the government and doing the trials. But I don't think that people put the pieces together. And then last remark, I think that at least looking from our perspective here, Brazil, we could do a better job in terms of making the data closer to people. And I'll give you a couple of examples. So you go to a critical care conference in Brazil, you have beautiful data like the one showed with outcomes of mechanically ventilated patients in Brazil, and the expert will show in his slides data from LungSafe. So LungSafe is a great study, but you know, it's not the same case mix, not same outcomes, not same population. And still, the local experts are not doing this well. And I think that there's something that could be done through interaction of registries, medical societies, etc., getting together. Who are the key opinion leaders? Guys, this is the data that we have. This is the best data we have. We have data on 5 million patients, 2 million ventilated patients. Where's the study showing this kind of data? No, it's in the registry. So you can use it and showcase this in your presentations, when you're teaching the students, etc. So I don't think we are there yet in terms of doing our best in bridging the gap, I would say, of communication with our own peers.
So I agree with everything was commented before, but I would like to add one more very important point. The leadership, I think, is very important. Leaders to convince the people to participate in the register. I think the inflection point is the leadership.
I think the important points are, I also think it's important for us to engage the newer people coming through. There are lots of people who actually have some data skills, but don't know the relevance of what we're doing. Mm-hmm. And their engagement in it will be vital coming forward. I think I would agree with all of the things that everyone has said. It's important to feed back the information so that it is seen to be useful. And the fact that it can be used and viewed in so many different silos means that it is so useful. But we need to make the message clear to people that and sell it. And sometimes I think we need to sell it with patient stories and sell it with more than just a graph, and sell it with engagement that involves someone, the nurse, the doctor, the data scientist, the health bureaucrat, because when we do it in the right way, they're engaged and they're part of it. But it can be really hard to do sometimes, I find.
So thanks everyone. I think that we don't have any other questions, but we like to do our closing, which I think is very important. It's not going to just be to say thank you, but rather to show a little bit and talk a little bit about future of this initiative, Logic, the next steps. So David and Pilar, please, I'll hand over to you.
Oh, well, let me start, and then I'll go to Pilar. And I think, George, you should also say some things, because this meeting, when we first started talking about this meeting was a trial run, is an example of how we can collaborate and how we can do a show and tell together for the people who are involved in registries, and use this as a stepping stone to future collaborations. Meetings are a way in which we can do this. I'm looking forward to being able to have similar online meetings next year, and also in-person meetings. There are conferences coming up where we can get together, and I'm hopeful that we can do that. But also there are many projects that are happening and that have happened previously. We've had research collaborations where we've been able to get pool data from different groups and doing it in a way that meets the requirements and meets the recognizing that it's easier to share countrywide data about your number of beds and number of patients. It's more difficult to share individual patient data, but there are steps in between that we can do where we can learn to collaborate, and we can do parallel analyses, and we can look at regional analyses, and all of these sort of things can feed into research projects. So I'm really looking forward to some of those developing forward. I might just hand to Pilar and George to actually, because there are a number of them happening, but I don't want to steal the thunder for the work that's been done by others. So I'm going to let you guys mention some of the ones that are happening.
Well, I'm really happy to have participated in this project day, and as Dave says, we need to have it each year, and we also have to invite the others that we know in our countries and our registries that have the same idea in mind, that are wishing to join, and you will you only have to write to our email of Logic, and sure, and you can propose this research that you have in mind, and I'm sure that there have been plenty of examples that, although the infrastructure is different, the characteristics of our registries our patients are different, but there's a huge work to lead this research, and to have good evidence, good local evidence published. And so you can also follow us in our social networks, Twitter, LinkedIn, and there we will be publishing the different projects we will work.
Thanks, Pilar. So, few last words. So first of all, thanks everyone for participating. I shared here on the chat the email for Logic, the website, in case you're not familiar with. And just mentioning briefly what David touched is the ongoing studies. So there are a couple of studies ongoing. One of them is led by Luigi Pisani, who is here also attending the conference today. He is leading a study called GRID, and it will be a very important study where we are doing a mapping of all registries to try to better understand what's behind the registries, what are the core data sets, what are the optional data sets, types of variables, stuff that helps us understand, but also helps us beyond mapping, try to shape and propose what would be common core data sets. There are other types of studies, and again, feel free to email us individually or on the Logic email if interested to participate, if you are a registry lead. Other studies, such as the follow-up to the current ecologic study that we have started, meaning using aggregate data at country level and doing ecologic analysis, trying to compare data over time and data among different health systems to understand the outcomes of mechanically ventilated patients. And finally, one interesting study to start next year will be the spring study. This one will have two levels, ICU data level and patient data level. That will be interesting to try to address the challenges of sharing data among different registries, and also to explore how creative we can be when this is not feasible. But this will be an interesting study to try to map also the staffing patterns, some of the process of care practices, and correlate to outcomes in different health systems internationally. So this is just a little bit of a flavor of what is going on. I think there's lots more to come in the next year. We really welcome new members and new registries that want to join. We've been growing steadily, but there's still more to grow. And for me, it was a pleasure and an honor to be here with you today.
Likewise, a big thank you to everyone for attending. Big thank you to the speakers, to George and Pilar. It's been a great experience. I'm looking forward to more collaborations to come.
Thanks also to IDOR team that helped us organize and set this up. I would not be able to do it myself. So thanks everyone. We're up early here to do all the tests, etc. So thanks to the IDOR team for the structure.
Well,
Cheers.
Thank you.
Thank you. Bye-bye. Bye-bye.
Good night from Australia.
Year. Bye.
Thank you. Bye.